Good morning, everyone. My name is Alima Komhanj, and I'm going to be facilitating this session. We are honored at Afya na Haki to have you all for this crucial dialogue on advancing digital health inclusion in Uganda. As we are in this group, we are really a diverse group of stakeholders, and we represent a spectrum of expertise, experiences, and perspectives in the realm of healthcare and technology. And we can all ascertain that we know that the transformative power digital health has in shaping our healthcare landscape. So we believe that it makes it more accessible, personalized, and efficient. And for it to be really impactful, we have to ensure that it is inclusive and it leaves no one behind. And that's the reason we are here today, that in this digital age, inclusion is not just a goal, but it is a prerequisite for achieving equitable and effective healthcare outcomes. So basically, we are here to be able to harmonize the varied perspectives that we are all going to bring onto the table. So to take you through the agenda, we are going to start with breakfast. We shall start with breakfast, but before we have the breakfast, it's good that we have breakfast when we know ourselves. So we are going to have a session of introductions, and then we'll have opening remarks from a representative here at Afya na Haki. And then thereafter, we shall have our keynote address by Mr. Muhumza Solomon, who is already around. He is a data governance and security specialist at the Division of Health Informatics, Ministry of Health. We are very privileged to have you, Mr. Muhumza, and thank you for honoring our invite. And then we shall go ahead and have the discussions. So with you, you all have the agenda. We shall all contribute to these discussions. So where you see the office that you belong to, you will be able to prepare for us some of these conversations. So without wasting time, I am going to invite Lenny. Lenny is going to set for us the pace for this symposium. She's an advocacy capacity enhancement officer here at Afya na Haki, and she is going to take us through this session of meditation and introductions, and then she will set the set. You're all welcome. Thank you.
Good morning, ladies and gentlemen and others. We are very honored to have you here with us discussing the theme on harmonizing perspectives, a stakeholder symposium on advancing digital health and inclusion. As Alima has already hinted on the rest of the discussion that we'll be having in this room, inclusion is a key part of what Afya na Haki stands for, but also we intend to make sure that it comes out strongly in the discussions that we will have today in this session. So I will just summarize the objectives of this meeting. We have two objectives. One is to create a platform for knowledge exchange, collaboration, and strategizing among key stakeholders in the digital health landscape. Now, we know that in this room, we have a couple of stakeholders from regulatory organizations, from app developers, from the legal fraternity, among others. Even community voices are represented in this room. So we think that this should be an opportunity to create a forum where we advance the conversations and discourse that are going to take place in this room. Secondly, we hope to discuss the challenges, harness opportunities, and harmonize perspectives for an inclusive and trustworthy digital health environment. And I think that all of us are better placed, and we are handpicked intentionally because we know you've interfaced with issues of digital health, and you can be able to help us identify the challenges and opportunities and how we take work forward in this area of work. So ultimately, we hope that a consensus document where all of us in this room agree to, develop practical steps forward to take forward work that has been discussed here. So that is one of the key things that we hope to achieve, but also just like I said in the objectives, we hope that this will be a forum for continuous conversation on the discourses that will happen in this room. You already have this, so I will not go on to read the target audience, but we hope that this will be as participatory as possible. Everyone's opinion is valid, and we hope that we will respect each other's opinion, but also have open and candid conversations. So we will move to the introduction part. We will introduce ourselves by name and where you work, or what your passion is if you don't have a specific place, office of work. But also, while you introduce yourself, would like to know your expectations, what you expect from this meeting. While we are discussing, thoughts might come to your mind, questions or comments. We have a parking lot right there. So you can, Stuart is going to distribute sticky notes where you can write those comments and thoughts that you think are very important and just pin them on that board. It can happen at any stage in this conversation, but you can also put expectations here if they are beyond what we can speak here. So without further ado, I will hand over the microphone. I'll start with Carol, then she will go around. After that, we will then have the tea break. Then we will come back for the keynote speech. Sorry, I think I'm forgetting something. We need to have opening remarks and a welcome address from Afya na Haki, and I will invite Mr. Nsereko, the head of department of the Advocacy Capacity Enhancement Department at Afya na Haki, to usher us into this conversation. You're very welcome, Mr. Nsereko. Let's give him a round of applause while he's coming.
Good morning. I'm already introduced by my colleague Lenny. Nsereko Ibrahim, I head Advocacy Capacity Enhancement at Afya na Haki. I'm not the Director General as indicated on the agenda. The Director General has delegated to me to give opening remarks on behalf of the organization. But what I'm going to share are my personal remarks, not the remarks of the Director General. So pardon me if I miss some things which you know are part and parcel of Director General's remarks. So dear our distinguished participants and speakers for different sessions, we are delighted and privileged to host you here at Afya na Haki Institute for the dialogue on digital health in Uganda. Over the past years, digital health was not a subject of conversation in forums, but increasingly after COVID-19, even during COVID-19, digital health became an issue that we cannot go away with, not only in the health sector, but also in other sectors in the country, but also at different levels, at the regional level and also at the global level. So as a research and training institute that uses Afrocentrism in health, human rights, and SRHR, we treasure having spaces for dialogue on critical issues such as digital health. So the symposium we are having today on digital health is not far-placed in Ahaki, but rather one of the key critical spaces that we treasure as Afya na Haki in ensuring that we can contribute and infuse Afrocentrism in conversations, including digital health. We are aware that our region in sub-Saharan Africa, we are always in many reports, we are labeled to have the highest disease burden in the world. The researchers will tell us if that is still the position. And we struggle with so many issues such as limited number of the health workforce. We struggle with access to facilities for services. We have so many, our road networks don't necessarily support or facilitate easy access to care. So we find that digital health is at the center and can be a key critical initiative to ensure that our people can be able to access healthcare services in the bid to achieve universal health coverage that we are all yearning to achieve as countries in Africa, but also as countries in the world. But before we go into that, we think it is important for us to trace back the history of technology in Uganda, but also in Africa. When we do a quick search, you find that the internet came to Uganda in the 1990s. So before that, we had no internet. How were people communicating? How were people transacting? How were people dealing with the rest of the world? We see in 1974, South Africa had the first internet connection. Later in 1995, we see many other countries, Uganda inclusive. We started having some connections of the internet. And currently, even in our local community like Nakwero, we have the internet. So we have made quite a number of strides in terms of embracing technology as Uganda, but also as Africa. The computers we treasure, I've seen some computers on some tables. They came in 1960s. You see that the first computer we had in Uganda, we had a few computers. And the computer we had would only accommodate 4,000 words. I think Makerere had some computers that they would use for research, and the Ministry of Finance. So other ministries didn't have computers. So what were they using to record data? How did the ministry collect data from the communities when we had no computers, when we had limited internet? But people were having also interesting indicators in terms of health amidst the absence of full-fledged internet and computers. Individuals also started using technology, like we saw Celtel introducing mobile phones. It was an honor for someone to hold a mobile phone in many communities, and someone would be able to reach if they had that big, I'm sorry to use the word big, but the phones were bulky, they were a little bit heavy. But now it's not a privilege for someone to have that bulky phone. People have very interesting smartphones which are very light, but very expensive. But also the bulky ones were expensive then. So we have seen a number of developments over the years in terms of ensuring people can be able to have gadgets that they can use to communicate, but also we see that with the entry of connections on phones in 1997 with MTN Uganda having wireless that we can access, we see that we have quite a number of changes that are positive towards ensuring that we can be able to access information on health, but also access services. So amidst, I think I can continue speaking. I trust my voice. I'm African, so I can speak without a microphone. So amidst all that, we see that by the time we received internet here, we had no regulations in place. We had no bodies to regulate, because we see that the Uganda Communications Commission came up in around 1997 to regulate the sector. There was no regulation. How were people handling data then without regulations in place? Something that we can discuss in this conversation. If we had no regulator, how were the people who were owning, for instance, Celtel, or MTN, or whatever player was in place then, how were those players handling the rights of people that were using their gadgets or were using their networks to communicate? So we find that there were a number of things that we may unearth in this conversation. How regulations were done then without any formal body, any formal law in place, no formal policy in place to regulate. But we see that there was some form of regulation within the community. So the community becomes very instrumental in our conversation. So we cannot run away from aspects like communal, like Ubuntu. How were people communicating? What was the common good that people were promoting throughout the
conversations. So I think that's very important as we discussed. Also commend the ministry for the Ministry of Health, the Ministry of ICT, and other ministries for creating spaces for regulation. Because we see that we have some regulations in place currently. I cannot conclusively say that they're exhaustive, but we have some regulations in place. But also we have users that require protection. If you develop an app and has no privacy policy, or the privacy policy is not rights-based, or it is not social justice-based, or it is not ethical-based, we see that we may have some struggles in terms of achieving the agenda of universal health coverage. So I think as we discuss, it is important for us to ensure that, to know that we cannot run away from digital health. We can't run away from technology at this age. But what is important is to go back to our roots. If we had no laws in place, if we had no regulators in place, and we had technology, or we had some form of technology, how are we regulated? If we have now laws in place, and we are saying they're not sufficient, and we are saying that we need further improvements, how do we reconcile the history with the current position? But amidst all those interesting developments, we had bone settlers. Someone would handle your fracture in another place. What technology were they using? What technology was being used to handle the patients? I hear it still continues up to today. What technology? Are they using internet? Are they using some force which is not known? So it is very important to go back to our roots as we discuss digital health. So I think it is important for this conversation to think about the roots of digital health, the roots of technology in Uganda, the technology in our traditional technology. I call it traditional technology because someone will handle you when someone is in Kampala, but you are in Nakwero, you are crying here. They are improving, they are working on your injury. So it is important to think about the roots, think about social justice issues, how were communities handling communication before we had formal technology, how rights, the place of rights in whatever we are discussing, but also how do we work together as app developers or app owners, as regulators. I know the professional medical bodies, you are used to licensing physical facilities, physical individuals. Now we have virtual health facilities, because if you receive healthcare through a virtual platform, I call it a virtual health center, a virtual hospital, a virtual art. So we need to see how we can work together. And I think the theme was very strategically picked because it's talking about inclusion. How do we have inclusion of all those issues? So before I conclude, I extend our appreciation to our key partners, the University of Warwick and Wellcome Trust for supporting our digital health initiatives at Afya na Haki through there is no app production of migration health data project that we have that is running in Uganda and other countries in Africa. But also we recognize the ministry as our key partner, Chipesa, one of our civil society partners, and the rest of the partners in the room. We thank you so much for honoring our invitation. Allow me to stop here and wish you fruitful deliberations. Thank you so much. Over to you, Lenny.
Thank you so much, Mr. Ibrahim Zereko, for those very kind words. He raises the issue of community engagement, and he also highlights that history matters. For us to chart our way forward, we need to trace our footsteps. So I think that should also be something that we keep at the back of our minds as we discuss. So let's go into the introductions. We need to know who is in the room. So I'll start with Carol over here. While we wait for a second microphone, we can use this one.
Thank you. Thank you. Good morning, everyone. I'm Caroline Ahimbisibwe. I'm a community mother from Nakwero. Glad to be here with you guys.
Good morning, everyone. By the name is Salongo Ukwa Elijah. I'm from Baobab, Sako. I'm their country representative.
Good morning, everyone. By names of Nakandi Maimona from Baobab Circle, Uganda. I work as the community manager. Glad to be here.
Good morning, everyone. I'm called Stella Dit, Head of Finance here at Afya na Haki. You're most welcome.
Good morning. Seroko Ibrahim. I head Advocacy Capacity Enhancement at Afya na Haki Institute. Nice to be here.
Good morning to everyone. I'm called Cynthia Danze. I'm a public health expert and I'm a fellow at Ahaki.
Good morning, everyone. My name is Edna Kasozi, Licensing and Legal Affairs with the Personal Data Protection Office. Thank you.
Good morning, colleagues. My name is Mpata Oagage. I'm a pharmacist and a lawyer, very interested in digital health. Thank you.
Good morning. Anton Wesaka is my name, and a journalist. So whatever you're going to speak, I'll putting it on record. Thank you.
Good morning, colleagues. My name is Muhumza Solomon from the Ministry of Health. I'm the Data Governance and Security Specialist there. Thank you.
Good morning, everyone. Name's Lillian Naroga. I'm a Digital Policy and Program Specialist at CIPESA. I'm happy to be here.
Good morning. My name is Patience Atkunda Jaffu. I head the Department of Informatics and Statistics at Ecure. Ecure is Ernest Cook Ultrasound Research and Education Institute. It's a specialist medical imaging institution and other degree awarding institution. Thank you.
Good morning. I'm Maurice Kabazi. I'm a fellow at Afya na Haki Institute. It's a great to be here.
Morning, everyone. My name is Sirius Andrew, Systems Administrator, Allied Health Professionals Council. I'm happy to be.
Good morning, everyone. My name is Onyait Patrick. I'm an advocate, a counselor, and I'm the founder and CEO of MindWatch Foundation, a non-profit organization providing digital and online mental health services like therapy.
Good morning, everyone. My name is Odongo Joel. I'm a lawyer and a director at MindWatch Foundation, interested in digital health.
Yes. Good morning, everyone. My name is Opio Isaac Peter, and I am the Executive Director of Techno-Legal Advisory Center, Uganda. Techno-Legal Advisory Center is basically a non-profit organization that addresses some of the challenges that we face in the digital society, and digital health being part of the digital society is a perfect platform for us today to share ideas and the views that we have to improve service delivery in this part of our digital society. Yes, so I'm glad to be here today. Thank you.
Good morning, everyone. My name is Marcia Wino from the Compliance and Investigations Department at the Personal Data Protection Office.
Good morning to you all. Sarah Kainza is my name. NITA, Uganda. I do regulation and compliance. Happy to be here.
Good morning, everyone. I'm called Obua Jonathan. I'm a pharmacist and interested in digital health. Glad to be here.
Thank you all very much. I note that we have very many experts in the room, and I know that this discussion is going to be extremely informed and interesting. We have online participants. I may not be able to read you out all, but you're welcome. Deborah, Dr. Edna, Hilda, Stephen, Ada, Amina, and others. We know that you'll be following this conversation. In case you have any comments, you can type in the chat and we'll be able to get to you in due course. I know that I had said after the introductions we would break off for breakfast, but I think that at breakfast we should also be having conversations to take forward what has been discussed in the room. So before we break off, I would like to first of all invite our keynote speaker to give us something to ponder about So our keynote speaker today is Mr. Solomon Muhumuza. Mr. Solomon Muhumuza is a data governance and security specialist in the Division of Health Information at the Ministry of Health. I will not risk to introduce him further than that. I know he will introduce himself. So Mr. Muhumuza, you're very, very welcome. Let's applaud him as he comes to take the stage.
Good morning, everyone. I'm seeing gloomy faces. I don't know if it is the hunger and whether I'm standing in between you and breakfast. But once again, my name is Muhumuza Solomon. I'm from the Division of Health Information, Ministry of Health. I'm the Data Governance and Security Specialist. And the word governance many times is a very complex word, because what has to be done many times is overarching or flowing over different aspects, but that is governance, and very many people don't like the word governance. But the Director General, Afya Hachi, in absentia, at least I've not seen the person here. Our government officials are present today, our private sector representatives, our civil society representatives, ladies and gentlemen, all protocol observed. It is a great pleasure for me to be here today, and I do recognize the presence of stakeholders that have turned here today for the discussions around stakeholder dialogue on digital health in Uganda. This gathering serves a testament to our shared commitment to leveraging technology for the advancement of health care and the well-being of our communities and ourselves as well. Therefore, it is an absolute privilege to stand before you here today at this pivoted symposium dedicated to advancing digital health inclusion. So, and for me, digital health inclusion starts by some of the aspects which were demonstrated as we're introducing ourselves. Our colleagues online, the digital colleagues online didn't introduce themselves, and those are the small aspects where inclusivity starts from. Why should we deny them an opportunity to introduce themselves, for them to be known and know the kind of audience that we have? So as we gather here today, we do stand of possibility, where the fusion of healthcare and technology has the potential to reshape the very foundations of how we approach wellness and patient care. So concerning technology, I'm seeing someone is checking the list, but we've moved forward. But concerning technology, the government of Uganda emphasizes the use of ICTs, information communication technology, as a means of improving service delivery, aiming at accelerating Uganda's digital revolution. And I know accepting that and practicing that in our daily lives, that's a new thing. It's something that we're accepting. Past the COVID-19, now it is the new normal that we should embrace. But specifically in the health sector, the government of Uganda's vision as per the Ministry of Health strategic plan, that is 2020, 2021 to 2024, 2025, is a responsive, resilient, and people-centered health system that protects and promotes the health and well-being of all the people in Uganda. We're not saying a few sectors of people in Uganda, but everyone in Uganda. And to achieve this, the plan advocates for acceleration of health research. So research is a core component to achieving and promoting health and well-being for all the people in Uganda. It advocates for innovation and technology development. as one of the 7 objectives of the strategic plan. So furthermore, Ministry of Health has developed and is currently implementing what we call the Health Information and Digital Health Strategic Plan within the same period 2020 to 2025, with a vision of the health sector in Uganda being driven by evidence and leveraging digital health to improve efficiency in service delivery. I know my brother here, Ibra, was talking about, you know, the remote binding of bonds, but here we're talking about evidence. You know, what is that we can quantify? Do we have the data, the statistics, the research being done? Is there evidence for us to be able to quantify, to be able to evidence the services that we are delivering? So I know that might remain a gray area for a long time. It's because there is no enough evidence to be able to quantify some of the traditional ways or means that we've been doing some of the things we do. So back to the strategic plan. Our strategic plan is grounded or anchored in 5 core principles. The first one being client-centered approach, knowing that you and I, the community, are the people who should be put at the center before we start talking about technology. And that is the mistake we make many of the times, is that we bring the technology before the people, putting the cart before the horse. So our strategy puts the client at the center. The second one is equity. I know that's what we shall talk about today, the fairness. The third one is privacy and integrity. We are in the digital age. I know most of us are talking about, you know, the privacy, confidentiality issues for clients, for the people who are receiving these services. The other one is efficiency. And we, in this plan, are looking at the best ways to be efficient. The government is not known for being very efficient. Many times, at least we have a very bad reputation in that area. But at least we look at technology to be able to be a vehicle for efficiency, to be able to cut down. And I'm very sure that this technology in many of the areas has been able to kick in and cut down some of the unnecessary costs. We are looking at transparency and accountability. We cannot start talking about inclusiveness if we're not looking at transparency and accountability, because at the end of the day, we have to hold different stakeholders to be accountable. So those are the 5 core principles in which our health information and digital health strategy is being driven on and being implemented. So these principles establish a foundation for advancing digital health inclusion. And now we embark on a journey of collective empowerment, recognizing the imperative need to bridge the gaps in digital health accessibility. We know there are gaps, and we shall be discussing these gaps today. So as we bridge these gaps, we should remember our commitment to 2030 agenda for sustainable development and its sustainable development goals. The commitment is leaving no one behind, all right? And as we deliberate, as we discuss, this should be at the center, saying that we shouldn't leave anyone behind. So as part of these efforts by the government of Uganda to the commitment of leveraging digital health to improve service delivery, to ensure that no one is left behind, we've embarked on rolling out the electronic medical records system at the health facility and community levels. So to date, the electronic medical record systems have been rolled out to 13 health facilities at the moment, including national and regional referral hospitals. We've started with the national level, but as you may be aware, in Uganda we have over 8,000 public sector health facilities. The private sector ones are also quite many, but you can see. But these are steps. It is something. We've also conducted a comprehensive ICT assessment, which has covered 56% of health facilities in preparedness to roll out this electronic medical record system. So we've taken steps and ensured that these facilities are ready for us to roll out EMR. I'll be talking about some of the critical elements or impairments that may deter our efforts towards achieving the digital health that we want. At the community level, we've rolled out what we call the Electronic Community Health Information System, or ECHIS, that has been rolled out so far to 12 districts. That is Koboko, partially. That is Koboko, Nebi, Lamo, Maracha, Amuru, Oyam, Bujiri, Kamwenge, Uyikwe, Ntungamo, and Mukono. It's only Mukono and Kamwenge which have a district and Uyikwe, which have district-wide implementation, meaning 100% saturation. The rest we've not yet achieved that. So, but on our journey so far, we've achieved 56% of those districts. So we still remain with a significant percentage to cover in the coming years. So the efforts still are underway to scale this technology to 36,000 community health workers across these districts by the end of the financial year 2025, and this will be covering about 25 districts in the country. So the progress of implementing digital health initiatives in the country, of course, brims with promises, but it's not devoid of challenges, and the challenges have been many. Challenges such as fragmented systems or systems which are in isolation, you find, and many of us suffer from that issue. You go to a certain health facility, we pick your details. You go to, you have an error card, but you still go to the bank, we keep giving our details over and over and over again. Is there a way that these systems can be integrated so that you don't have to keep giving all these details? And it's even funnier these days that, even if you have a copy, for example, of your ID, someone insists, I want the original one. Can't you use this information that have availed to you to be able to verify my identity? So that is the fragmentation that I'm talking about. Even within the health sector, the systems are not well connected, they're disjointed at the moment. For example, where we're rolling out the electronic community health information system, it enables tracking of a patient. For example, if a child is born, we record that the services that the child has received over their lifetime. But imagine if this child now goes to, maybe they are sick and goes over to a health facility, it will be like this person has never interacted with the health sector. And then we have to pick the details again, and the health workers miss out on the patient history, which would be very key in diagnosing this particular patient. We've had issues of duplication of efforts. We've had multiple partners investing in the same thing. Everyone is trying to do their own thing, not knowing that if we had concerted efforts, if we put resources together, we could actually achieve much more. Poor infrastructure. We are talking about inclusivity, but when you look at the rate of electrification within the country, it stands about 24%. What happens in the other part of the country? How are we going to roll out digital health initiatives if we don't have power? Because power is a big driver of this digital health. We are looking at internet penetration. The rate stands about 25%. I know when we are in Kampala, you think everyone can get internet. But I like it when we get that rude awakening, when we go home for Christmas, and you have to station your phone somewhere in the living room or the dining. That's why you are able to get internet connection. Besides that, other places. But that is a reality of the people who are staying in these places. We are preaching digital health. We are pushing digital health. It's not going to happen if we don't have this critical infrastructure in these places. We're talking about, I've talked about, you could ask me, Solomon, why is it that you've reached 13 health facilities? Why is it you've reached about 8,000 community health workers? The issue is finances. We don't have the money to be able to push and scale throughout the country. So we've seen the issue of limited financial resources, the human resource. Our curriculum doesn't, the earlier curriculum that we had for health workers wasn't involving IC training for health workers. So they are qualified for the work they do, but they are not ready for these digital health initiatives. Some of them even fear these computers, some of them, but that has changed now. We've been able to put curriculums in place, targeting them, but you see that this has to be a systematic effort, something that is embedded way before and it becomes part of life. It's the way we work with right now. You can't work without your computer, and you know, it has to be there for you to be functional. Those are the things we should be thinking about. We also have, you know, the poor mindset change, and I know we've been pushing at Ministry of Health, we've been pushing, you know, digital health initiatives, but you know, it's like people are overwhelmed when they look at the technology. It's like, I don't know, you sitting in a self-driven car, you'd even be scared and worried whether it will make you reach home. So this is the mindset. It takes time, but we need to have very deliberate efforts to be able to achieve this. So towards digital health inclusiveness, we've seen challenges such as accessibility barriers. I'm going to talk about that in a few. Disparities in technological literacy is what I was talking about. Socio-economic constraints, you know, and regulatory complexities, which I'll also talk about in a few, often hinder path towards inclusivity and underscore the urgency for collective action and innovative solutions. So our mission today is profound, yet very straightforward, isn't it? So our mission is to decipher the intricacies of digital health inclusion today. It is about understanding the diverse needs of communities themselves that we live in, addressing these disparities, these issues they have, and fostering collaboration among stakeholders. And I'll repeat, collaboration among stakeholders, because we are people who are working in isolation, and we need to improve on that. Let it be policymakers, healthcare providers, technology providers, even the public itself and the communities, they should be brought to the table to be able to speak to these issues. In my keynote, I've come up with domain areas where our action, I think, would be needed to be able to foster conversations around digital health inclusiveness. The first one is infrastructure, and I've already mentioned some of these things. This will enable everyone to access digital health care if they choose to and experience the benefits. So when I talk about, we talked about some of the challenges being accessibility, you know, being a barrier, but what does that mean exactly? You understand? So if you don't have a smartphone, for example, or if you don't have a phone, it's difficult to be able to consume some of these digital innovations, solutions, initiatives that we have, isn't it? So, and we look also at infrastructure in terms of you know, us having computers out there in health facilities for our health workers to be able to utilize this infrastructure. We look at, the other day, when we are rolling out some of these systems, the focus every person was talking about is buy computers. We need computers. And then when we reach the ground, the health facilities, they don't have the local area network to be able to, you know, to be able, first of all, the local, including power itself, to be able to exchange information, to be able to be powered up, to be able to connect to the internet. So infrastructure remains a key limitation. As we discuss inclusiveness, this is an area that we need to give special focus. You know, infrastructure, and if you go broadly over the areas of digital health, I know many of us complain about roads, but that is one of the classical examples. When I was coming here, in my mind, I'm like, these roads, there's really, it's equitable. Everyone is suffering from the same problem at the moment because the roads are terrible. So infrastructure is the same thing that we need to work on. The other issue is internet connectivity and the cost. We've had several projects with NITAU, which is rolling out the backbone infrastructure for purposes of connectivity. But you know, when you look, I've already talked about the internet penetration rates being about 24, 25%, but is that enough? What happens to the other percentage, you know? And will they be able to transmit? We are actually conducting the net campaign, and we are using digital means for capturing data and doing all that. But there are regions right now, as we speak, we are opting for hybrid, being able to use paper, because the entire sub-county has no network connection. People there even don't have phones. For us, that's what we call digital poverty. You know, they don't have phones, there's no power anyway, so it does not make sense. So we have to get this data, collect it, and here we are talking about this health facility that is remote, and we're talking about inclusiveness for them to be able to utilize and also partake in the advantages, opportunities that are presented by digital health. What are we going to do for such places? The other issue we should be talking about is digital health applications themselves. Are they accessible? Are they easy to use? I talked about some of the principles for our strategy, and we think that putting user-centered digital health solutions are very key, and ensuring that when we are designing those solutions, there is co-design, they are co-designed. We're involving the communities, the expected users to deliver the excellent patient outcome that we are looking for. And before I leave this point, you know, people need to trust these solutions. It's very key for them to trust them so that people can understand and feel confident to utilizing these digital health approaches. I'll be speaking about telemedicine and the rest. But the fourth one for us we're looking at is the digital health workforce, but particularly we are looking at skills and capacity building. I'd mentioned our curriculum way before didn't have that. So there is a gap which we need to address. As we speak of digital health, we have community health workers who are volunteers, who have been working for a long time. Now, the digital aspects are coming in and we are saying, okay, you step aside because you can't operate a smartphone. Is that a fair thing to do? Someone has served for 20 plus years and now you say you can't use a smartphone to deliver the services that you want. So we really need to come up with programs which can take someone from 0 to 100 to be able to utilize these tools. And when we speak about digital health, very many times we forget ourselves as well. Have you thought about your grandmother? Have you thought about your dad or mom in the village? They are tools for them which are essential to use. Recently, I introduced my mother to using a wearable device to be able to track their heart rate, their pressure, you know, their sleeping patterns at night. For me, it makes sense because these people need this much more to be able to monitor their health, because as you grow older, your health is a bit compromised. That is something she can't live without. Nowadays, you know, even if it's broken for a day, she will call me and say, Solomon, my tracker is not working, what is happening? It helps. Every day it is a culture for her to check in the morning, see how her sleep was, what the pressure is like, you know, and these are solutions which are meant for some of the people. So we are talking about inclusiveness. Many of us just think of, you know, health facility, or we think about ourselves, but we forget the real, some of the people, the elderly. When we talk about inclusiveness, we are looking at age, we are looking at gender, and those are some of the people we target. We are looking also at digital health financing. We are talking about digital health a lot, but we are forgetting where the finance is going to come from to support these digital health solutions, these digital health innovations. The sixth point is leadership and partnerships, so that digital health inclusion efforts are coordinated and we help to reduce on health inequalities. You know, everyone is trying to do something about either inclusion or digital health, but we are doing it in a siloed manner. We are not coming to the table to, you know, to collaborate. as they say in an African setting, that if you walk alone, you'll walk fast, but you won't go far. But if we walk as a crowd, we shall definitely reach further. The other one is privacy and confidentiality. We need enabling frameworks in place. At Ministry of Health, we've just drafted the telemedicine guidelines. We have telemedicine. And one of the things I would like to talk about, Ibra was, he putting forward his thoughts. Let me assure you, innovation is always ahead of legal frameworks or legislation. Very many times we are talking about AI. Right now, there are no legal frameworks to be able to govern that. What telemedicine has been in Uganda for years, we still don't have legal frameworks which are appropriate to address it. So innovation will always be ahead. We should embrace that for the good of things, yeah, and in a way it survives and thrives. But of course, we need, going forward, to be able to scale, looking at the impact that might have on our patients or clients. Then we need to think, of course, about the legal frameworks. But for me, I think what I would advocate for is ensuring that these frameworks are developed in a timely manner so that the gap between the innovation and the regulations is not so big. We've had mobile money for so many years. It wasn't being regulated. Taxing it was a problem. Keeping your money on your mobile money platform and them giving you an interest over time has just been, enforced of recent, but all those years it wasn't enforced. So technology or innovations will be ahead of their time, but we as stakeholders today who are advocating for inclusiveness, we really, and it comes out through collaboration. That's when we can tackle this issue, the time lag between when the innovations are out there and when we have the regulation. So I therefore challenge everyone here today in this room to seize this moment as an opportunity for collaboration, knowledge exchange, and collective problem solving. We have the same problems. They affect all of us, not just a single or a target group of people. Let us work together to create an environment where digital innovations flourish, where technology is a force for inclusivity, and where our citizens can benefit from the dividends of digital health advancement. Each stakeholder here today brings a very unique vantage point to this symposium. You bring experience, insight, and different aspirations. It is in the convergence of these varied perspectives that are in this room today where our strength lies. So our strength lies in diversity. Let us listen, learn, and collaborate to amalgamate these diverse insights into actionable strategies. So our discussions today will transcend the rhetoric. They are a call to action. Let us explore pathways that foster inclusivity, cultivating digital literacy, ensuring equitable access to technology, designing culturally sensitive solutions, because we are moving digital health innovations forward, but we are forgetting about the culture, and I'm glad that Ibra talked about it. So we need to look into the cultural aspects, fortifying policies that prioritize inclusivity as a cornerstone of digital health initiatives. So in this era of rapid technology evolution, we must not only embrace change, but actively contribute to shaping this change. Our collective vision should transcend the confines of borders, ideologies, uniting us in a shared pursuit of a healthier and more resilient future. So collaboration, once again, stands as a foundation of our endeavors. It is through united efforts, drawing upon the strength of the public-private partnership, leveraging technology innovations and valuing community engagements, that we shall bridge the divide or gap and bring digital benefits to all. I applaud the leadership here at Afya na Haki for mobilizing us today and for coordinating with stakeholders to come and have this dialogue on digital health in Uganda. Let us seize this stakeholder symposium as a catalyst for change. The seeds of inclusion that we plant here today will definitely blossom into a future where digital health is a right. Is a right and not just a privilege as it is at the moment. It is through these collective commitments, understanding and collaborating, that we can pave the way for a truly inclusive digital health ecosystem. Thank you for your dedication for this cause, and may your shared journey towards digital health inclusion be one of progress and transformation. Thank you very much.
I think that's not enough. Thank you very much, Mr. Muhumuza. You people will agree with me that we had the best choice of a keynote, right? Yes. So you're very, 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 very knowledgeable, and we thank you so much. So I would just like to pick a statement that Mr. Muhumuza said. He said that the essence of this dialogue or symposium is to decipher the intricacies of digital health inclusion. And on that note, I apologize to our online community. We did not give you the opportunity to introduce yourself. I don't know, Drake, how many people do we have online? 10? So do we agree that they introduce themselves or not? Okay, so let's hear from you in the spirit of inclusion. I'll just read out your name, then you'll tell us, you'll introduce yourself very briefly because our time is very fast spent. So we'll start with Deborah. Deborah, please unmute if you can hear us. We'll move on to Dr. Edna. Do you hear us, Dr. Edna?
Yes, I can hear you very well. And may I ask, do you hear me?
Yes, please introduce yourself.
Okay, as it was said, my name is Dr. Edna Harriet Mtoy. I am a lecturer at the Higher Learning Institution, and I'm here today because I'm interested in healthy issues because I'm running a course at the bachelor degree on gender issues in health. And I think being here today, I have picked some of the important information which I might need to include in my class as a lecturer and maybe as a researcher as well. Thank you so much.
Thank you so much, Dr. Edna. We know that your expectations will be fulfilled. So let's go to Ada.
Hello.
Hello.
Yes, morning everyone. Protocol observed. By names of Ada Tulekensi, a researcher, nursing officer, and I'm a candidate postgraduate diploma in medical education. I do teaching at tertiary institution, specifically in nursing, and having attended this, it helps me to bridge the gaps that exist, especially in the use of the digital equipments in our teaching, and also as far as research is concerned, do you realize that this system has partially been implemented and henceforth it leaves a gap in the use. So as a researcher, I've picked key things from the main speaker. Thank you.
Thank you so much, Ada. We'll have two more people. We request you to forgive us. Please introduce yourselves in the chat, and we should be able to know you more later on. So I'm going to pick on Mr. Mubiru, Stephen, and Patrick Sam, because we've already had females speak. So let's have Mr. Mubiru and Patrick Sam introduce themselves, then we can go on with the agenda. I think the rest of us can introduce ourselves in the chat. We'll be so delighted to know more about you. So like I said earlier, our time is fast spent. We are over 20 minutes beyond the time that we had allocated for these sessions. So please allow me, I know food and refreshments are a human right, but we will have to reduce the time. So instead of 30 minutes, we request that you have your breakfast in 10. And the breakfast is just outside. You'll take your left and there's a cafeteria, so you'll be able to serve yourselves. So we are breaking off at 10:48. We should be back, what's the time? Yes. So at exactly 11, we should be here. Please help yourself to breakfast. Thank you. I want to get another chair. I want to get a small. I want to get that chair. Okay, we're very welcome back from the tea break. It's 2 minutes past 11. I'll just give 1 minute to people who are still outside to settle in. All right, once again, you're very welcome back from the tea break. At this juncture, we would like to... Thank you. So we would like to delve into the crux of the matter, the discussion from you various stakeholders. And I'm going to hand over to Alima to take you through this next session. However, we also have this space in the middle. If you feel like you are tired of sitting behind the desks, you can feel free to relax here in the middle. Alima, you're very welcome.
Thank you very much, Lenny. Feel like they need to stretch, you can join Ibrahim and relax on those cushions. They are very comfortable. But if you're still comfortable where you are, then it is well. So we are going to go direct to our discussion sessions. And the first discussion session is going to be looking at data protection and privacy. And we are also going to look at the institution, the policy, and the regulatory frameworks for digital health inclusion. So I am going to invite the following persons. And like Lenny said, it is not good for me to risk and introduce persons. So I will just call them and then I will give them a minute each to like introduce themselves as I call them. So I will start with Jerome Mpata. I've been struggling to pronounce his name like since. And yeah, I have been reading about him as a pharmacist and as a lawyer, and yeah. So, all right, so I'll give Jerome an opportunity to introduce himself as I prepare to call the next person.
Thank you, Alima. Thank you, colleagues. My name is Mpata Jerome Owagage. By qualification, I'm a pharmacist and a lawyer with a specialization in health and medical law. By practice, I am many things. I am still a practicing pharmacist. I also do a lot of legal consulting, and I also teach law. So I think that's sufficient, and I'm looking forward to the discussion that we're about to have. Thank you, Alima.
Thank you very much. What a very good match. If we are looking at health providers, he's there. We are looking at people who understand the legal things, he's there. So we are privileged to have you, Jerome. I will also give her the opportunity to introduce herself. She's one of the persons from the civil society organization. Lillian, you can take your seat next to Jerome.
Thank you, Halima. I think I bring color next to my neighbor here. The mic is kind of, favorable. Seems someone whispered to me to, bring some femininity into the discussion. Hi, good morning, everyone. You already heard my name is Lillian Naroga. I work with Sipesa. Sipesa is quite a mouthful, which is the collaboration on international ICT policy in East and Southern Africa. We are a technology and research-based organization. We do lots of research on where we try to find the intersection between technology and development. So we do quite a lot of research and advocacy in this area, and health is one of the other areas that we cover under our data governance program. On another note, I think some of the people here know me as, I represent also the Internet Society Uganda chapter. I'm a co-founder and a technical advisor. And that also looks at different aspects of how we use the internet. And if we are looking at digital, of course, the underlying issue there is internet. And I'm happy to be here to hear from my pharmacist lawyer, who I may not want to sue in later stages if I get expired drugs.
Okay, that is interesting. So we are suing a pharmacist who is a lawyer. So the next person is going to be Kabazi Morris. Morris will be representing very many constituencies for inclusion perspectives. Please take a seat next to Lillian.
Thank you. Good morning to you. I'm Morris Kabazi. I'm here on behalf of very many marginalized communities in Uganda. I'm not claiming to represent them, but I'm claiming to advocate for a legal kind of reform, change, and sort of give that discourse for the sex workers, the LGBTI persons, the persons with disabilities. We cannot have a conversation on inclusion without appreciating the different gender diversities that we have. And of course, it's going to be challenging to talk about digital health. I've done an analysis of the Data Protection and Privacy Act with respect to the LGBTI persons in Uganda through Human Rights Awareness and Promotion Forum. But in this space, I should not be afraid to talk about inclusivity. I know some of you already know that we have the Anti-Homosexuality Act. From here, I might be arrested for talking about issues of, it can be called promotion. Yeah, but this is a safe space to talk about data, digital health inclusion for the marginalized in Uganda.
Thank you, Maurice. We take the disclaimer seriously. And we know that you are discussing the issues, but you're not a representative. Thank you very much for clarifying that. So the next person is Mercy Awino. Mercy, you look shocked. I will give her the opportunity to also introduce herself.
Thank you, Halima. My name, as introduced, is Mercy Awino, and I work with the Compliance and Investigations Department at the Personal Data Protection Office. I am a lawyer by profession and also a social justice advocate. Thank you.
Are we tired of clapping? So all our issues to do with data protection, security, we have Mercy. She's going to cover that. Last but not least, I will invite Mr. Muhumza Solomon. We request that you return. Do you want him to introduce himself again? Okay. So we have really tried to be gender sensitive. Our panel is really very balanced, and I like the way you're sitting. So without wasting time, I don't know, maybe Mr. Solomon wants to say this. Maybe you could have introduced yourself and left out one key thing. You could say it now.
Good morning once again. Muhumza Solomon is my name. By profession, I'm a telecommunications engineer and a computer scientist as well. Very many people. I also get surprised when I'm introducing myself. I remember I'm an engineer, but that's my background. And as you know, technology is new in these sectors, and I've since joined in advancing technology for health. Thank you.
So thank you, everyone. We are going to go direct to the discussion. My name is Alima Komhanj. I'm a public health specialist and an M&E consultant. I work here at Afya na Haki in the Department of Advocacy, Capacity Enhancement. So I'll be moderating this session, and I am very privileged to be the one in before you. I do not want to put anyone on the spot. So the questions, there are really no questions. I expect that you're going to give us the views on policy and regulatory frameworks. So I will start with Jerome to tell us what is it that we are doing well in terms of the policy and regulatory frameworks that we have for data inclusion, and if there are any bottlenecks or gaps in these frameworks.
Thank you very much. Lima, first I wish to recognize that on this panel, I think it's just a lady next to me that I haven't met before. Mercy and I were classmates, so was Maurice. I met Solomon at the National Conference for Health and ICT a few weeks back. So very familiar faces, and we are having or continuing to have the same conversations. Now, when it comes to policy and law for electronic health, first, I think we need to have a very segmented conversation that places the issue within the broader global context. I think everyone here in this space will agree that when we speak digital health, we are speaking the right to health, and the World Health Organization has explicitly said that digital health is one of the avenues for achieving Sustainable Development Goal 3, which, as you may know, concerns or is a health goal. So digital health is a pathway to achieving universal health coverage, and by that achieving SDG 3. And especially in resource-limited settings like Uganda, it's doubly important because advanced economies have obviously better healthcare systems, but the edge that digital health brings to countries like Uganda is that we can be able to access fast world health services through the medium of the various digital health platforms, as the ICT engineers will tell you. Now, so I wanted to bring it from that obligation or international obligation level that we have as a country to ensure that our population has universal health coverage. Then we come to the supreme law of the land, which is the Constitution of the Republic of Uganda. Under Article 189, the government has a duty to set policy, including health policy. And so when I see Solomon here, I know he's coming in from that aspect of the conversation. But as you may know also, we have such a thing as national objectives and directive principles of state policy. And there's been some litigation. I think Ibrahim and his team, I don't know now which is SEHAD, which is Afya na Haki, but I know that SEHAD has litigated on this question in 2013, I believe. And the Supreme Court was clear that the objective principles and the national objectives and directive principles are justiciable. It means you can commence proceedings or enforce rights based on them. But also the Constitution was also amended to provide some leeway under Article 8A. But all I'm saying is what was said by the court in SEHAD versus the Attorney General. So what does this mean? I think that those that are in the advocacy space, including Afya na Haki, should be a bit more disruptive and put Solomon and his team to the sword, because there are clear constitutional obligations on the state to ensure that Ugandans have or access health services and enjoy the right to health. So a lot of times people will say, but this right is not included in the Bill of Rights under Chapter 4, but the truth is we have Article 45 to answer that, which says that what we have in Chapter 4 is not a shopping list, it's not an exhaustive statement of rights owing to Ugandans. So I think in that way we have a sufficient legal framework for the rights users or those agitating for them. Now what then we need to question, coming to your question, Alima, is whether we have an institutional mechanism. And when we speak institutions, we have to give a broader perspective. The first institution in my view is Parliament, which under Article 79 has a duty to legislate on all matters, including health. So I would say we have had some institutional failure there because we don't have an act of parliament that is specific to digital health. Mercy will tell us, well, we have the NITAU Act, which creates the Data Protection Office and defines substantive rights. The NITAU Act, and in combination with the Data Protection and Privacy Act, which creates two important institutions. One is NITAU, the second is the Data Protection Office. But I've always been of the consistent view that when you look at Section 4A of the NITAU Act, it makes NITAU more of a government-centric entity, and we are speaking inclusion here. Because Section 4A says NITAU shall service the government's ICT needs, and so it's clearly an entity that is postured as responsive to the government's ICT needs. But as we've heard from Solomon, we have parents in the villages, we have regular Ugandans, Maurice will tell you we have other excluded populations, and all these need to be included in the conversation on e-health or digital health and the institutions that the various instruments provide. So I personally do not think that the NITAU as an authority or even its legislative framework is designed to engender inclusivity. Now, we also have other institutions like the court system, because obviously if we have parliament legislating, then we need the judicial institutions and mechanisms that are going to bring to life these instruments. Now, I think by and large, in very few cases, the judiciary has been relatively open, and Ugandans that wish to enforce some of these rights, I think, have received a cordial welcome to the institution of the judiciary, so that's the other institution. But when it comes to an institution that is focused to digital health, I have still felt that it is, what we have now, like I've mentioned previously, is Electronic Health Technical Working Group in the Ministry of Health, and this I think is a product of the National E-Health Policy. But I don't think that it rises to the level of what we are trying to do. If we are speaking something as significant as Uganda's obligation to the SDGs, one would have thought that we would have had perhaps a higher level institution whose business it is to regulate and assist or promote electronic health In fact, in many of our policy documents, if you look at the National Development Plan 3, the one we are implementing currently, you realize there is an entire chapter on digitization and making services electronic. So the short answer, that is the long answer to your question, but the short answer, I believe we have done some things well to the extent that we have an enabling legal environment, but obviously it is challenged by the inadequacies that I've just pointed out, to the extent that we don't have a dedicated authority that responds to e-health. We have our law cast in so many places, the NITA-U Act, you have the DPPA, you have the Constitution, the Electronic Signatures Act, Electronic Transactions Act, and there is no coordinating entity that brings all these different elements together. One would have thought that it would be NITA-U, but I still, think that NITA-U is too government focused. So in terms of what I think should be done, I think it's exactly that, to get an entity that sort of coordinates all these efforts in order to have a more robust e-health environment and perhaps even better inclusion. Thank you.
Thank you very much, Jerome. That was really powerful. So I pick on the institutions that you mentioned. You talked about Parliament, and then you spoke about NITA, probably even DPO, and then the court systems that we have. But one of the things that you mentioned, like we are doing well, is that we have tried to have an enabling legal environment, despite the fact that we do not have persons who are directly responsible to respond to our e-health solutions. And there is also one perspective that you actually mentioned in terms of the challenge, where you say that there is no single act that specifically speaks to e-health. I think Mercy will be better placed to address some of these issues. So in terms of what Jerome has mentioned, and you being part of some of these regulating bodies, what is your take on that? Sorry, we are using one microphone.
Thank you. So as Jerome stated, that there is a whole part of our NDP3 that is dedicated towards digital transformation, and obviously health would fall under that, as other sectors of the economy are going through the digital transformation, even the health sector is. And in the keynote address, Solomon was very emphatic on that, the fact that there are actually innovations that are in place, but even in terms of policy frameworks, that the Ministry of Health has come up with certain policy frameworks that now have inclusivity and digital transformation in the health sector. And when you look at the 2023 SDG report, what it says on SDG 3, which is on health and well-being, you see that the score for Uganda shows that we are steadily improving, but we have still not yet reached a stage where we can now say that it is sufficient to actually achieve the goal. That shows that there are certain gaps and certain challenges that are that we experience as a country, as a nation, in terms of having frameworks in place, but even tangible progress in achieving the right to health. Now, in terms of legislation, as Jerome was deliberating, we have the Data Protection and Privacy Act that is in place. And it is true that we do not have a single act, primary legislation, that speaks towards digital health. But, and I don't want to sound very politically correct or to buffer the government, but you see, in the case that he mentioned in Sehad versus the Attorney General, one of the things that Justice Lydia Mugambe was talking about was the fact that, you see, we, as a state, because we do not have enough economic resources, sometimes it can be understandable when we do not achieve the goals that we aspire to as a country, but also under international legal frameworks. But what then is the standard to show progress? That we need to have some sort of progressive realization that indicates that the state is committed towards achieving the aspirations that it has. In the sphere of health, what is the nation doing? Solomon will tell you that there have been policies that the Ministry of Health has put in place to regulate the digital health sector. And nationally, as I have just said, we have the Data Protection and Privacy Act that when we give a broad definition towards some of the provisions that it gives, then it could also be, it is applicable in the sector of health. When you look at Section 3, with the principles that it gives, that as you're collecting data, there are certain principles that every data collector has to abide by. So who is a data collector? First of all these health facilities are data collectors. They process data and they control the data, because then they determine how this data actually is used, how it is stored, how it is transferred to different entities that then have the mandate to use it and to provide health services to the people. When we talk about the digital health solutions, digital apps, health apps that are there, do we have regulations for them? Yes, we do. And of course, the contention would be then in terms of implementation. How far have we gone to actually implement the regulatory frameworks that are in place? We might not necessarily be at 100% perfection in implementation, but we have policies that are in place. So maybe the conversation then should be, how do we get the policymakers and the people who have the mandate to implement the policies that are existing to actually do their job in a more efficient manner, in a manner that actually protects the rights of the data subjects and also holds accountable the data controllers. I know that the Ministry of Health has very recently put in place a privacy policy and notice actually for digital health services, and it might not be already like endorsed and published, but they are making strides in doing this. So, but then there is also the dichotomy between the public health institutions and private health institutions, because usually in regulation, that is also kind of a challenge. So how do we hold private health entities accountable? Because sometimes most of these private health entities, they have been put in place by investors who are not necessarily Ugandans. And so there is a lot of sharing of data across, there's a lot of cross-border data flow for patients. In the keynote address, Solomon spoke about the fact that, you see, now we are having we have telemedicine, but also he spoke about the electronic medical systems and how, they have been rolled out in 13 districts now. But then for this to actually be successful, we need to have integration of the APIs that exist. But that also presents a challenge, because when you integrate most of these things, then it also creates a security challenge. Are we equipped enough to handle those security challenges that exist? Do these health facilities have robust security mechanisms? Even because, you see, already without computerization and going digital, we already have data protection challenges in our health facilities. There was, on social media, someone said that, they found medical records of HIV patients, Now, when we're using hard copy records, we already have these challenges. In the digital sphere, that's something entirely different. Do we have systems in place to ensure that when we integrate APIs, when we get online, we have enough protection for clients' data? But then also he talked about the curriculum that is being put in place for health providers so that they can incorporate ICT in the health provisions. I think it's an important thing that maybe you also need to include data protection and privacy in that curriculum, so that it's not that you just know how to operate the computer, but there are certain information security principles that you need to abide by in order to make sure that the patient's data and the client's data is actually managed in a proper manner, so that we keep the citizens safe, but also maintain integrity of health data. Yeah.
Thank you very much, Mercy. I'm going to direct this to Morris, but before I get to Morris, there are some good things that Mercy has mentioned that are already in place. Apart from the enabling environment that Jerome spoke about, she says, of course, we have these policy frameworks that already have provisions for data inclusivity. You talked about the Data Protection and Privacy Act, and then also about this curriculum. So for me, the bottleneck that I see that you have mentioned is basically in terms of the implementation. Like, how do we get all these policies and acts to really be efficient, and also how do we hold the data controllers accountable? And you also mentioned about the private health entities, and I know we have many private health entities around, and they should be able to tell us who is actually holding them accountable, or who should actually be holding them accountable. So to me, there are so many issues here that I think, I don't know whether Solomon is in trouble or not, but it seems like everything focuses on government. And for now, we shall take Solomon as our government, and then we direct the questions, though ideally we are the government. But for today, we shall allow Solomon to be on the spot for that. But I would like to know, in terms of all these policies, the frameworks that they have been mentioning, the acts, Morris, do you think that these frameworks that they have mentioned, because I know Jerome said that we should be more disruptive and we put the government on the spot. So for me, I want to know, in terms of when we talk about inclusivity, we look at these marginalized populations, and then we see, do you think that these policy frameworks, the acts that have been mentioned, have catered for persons with disability, have catered for persons living with HIV, and then we have the other constituency that I have mentioned? I hope we remember. So, Morris, would you speak to that in terms of basically whether you think these policies, the institutions are really representing the marginalized persons?
Thank you. In my analysis, most of these laws lack a human rights-based approach. And if we are to consider the applicability of human rights to digital health, we need to consider privacy, we need to consider dignity, we need to consider all the encompassing human rights. They all apply to the marginalized persons. In Uganda, we have progressed in defending some of the human rights for our key constituencies, the key populations, especially the LGBTI persons. In the case of Victor Mukasa versus Attorney General, we also have the case of Kasha Jacqueline versus Attorney General versus Rolling Stone Limited. In that case, the court recognized that despite your sexual diversity or orientation, all these human rights apply to you as a human being. So all our laws must reflect that position. Unfortunately, as I speak of today, we have laws that are oppressive, that are undermining some of the rights that have been set, which are malleable to digital health in Uganda. the data privacy laws that we have reflect the position generally across all the populations in Uganda. You have the right to be forgotten. You have the right to be protected, your data. There is some sort of accountability. However, if we are to talk about protection of my data, you also need to consider the ethical standards. Do you have a duty to report? Because if I come to use my app to access teletherapy, because in the community we have higher levels of depression, we have challenges because of the discrimination that we face as marginalized persons, we need to access some of these services from a distance. Because of the homophobia, because of the discrimination based on your status, you are not likely to access some of these services through a health service provider, let's say a health center. So teletherapy could be one of those mechanisms we can utilize. However, if we have laws that are contradicting some of the access, the privileges that we should all enjoy as Ugandans, we are likely not to enjoy these rights. You know, this is a call to your government. If you realize that, I know the Ministry of Health has come to clarify that you should provide health care to all persons without discrimination based on sexual orientation. You need to also give us a commitment, roll out a commitment, a guidance to how digital health should apply in all aspects of discrimination. Should we be afraid of accessing digital health care because of that duty to report? For instance, under the Anti-Homosexuality Act, Section 13, I think even Section 11, with regard to the duty to report. You know, the privilege of not reporting applies only to the advocates, the lawyers who have that professional privilege. When it comes to your counselor and you're seeking support, maybe you've gone through a gender affirming care or surgery, and you need some sort of mental health support, do the digital health laws provide for non-discrimination? Because discrimination is the biggest issue that the community is facing. And if we are to really protect ourselves as the marginalized groups and to be able to enjoy and participate in this, in healthcare, especially through the digital infrastructure, we need to have an assurance that there's not going to be discrimination. So we need to go back to the drawing board. Do our digital health laws, all the laws that have provide for digital technology or digital related rights, do they provide for a human rights-based approach, especially on aspects of discrimination, non-discrimination, or based on disability, based on HIV status, based on sexual orientation, based on experiences of, you know, ethnicity? We need to have that clarification. However, for our country, Uganda, we also need to ensure that the policies that we have in place, who do they speak to? Who do they apply to? We most of the time the policy frameworks are targeting the stakeholders, who is going to implement what. However, if we are excluded as the constituencies that are recognized as the marginalized in Uganda, at the passing of the anti-homosexuality bill, one of the members of parliament was saying that we don't recognize LGBTI persons as key populations. We don't recognize them as key populations. Who are the minorities? We only recognize women and persons with disability. We need to have a more inclusive language that is not going to deviate from human rights, that is not going to deviate from the application of all the rights that have been set out in the Constitution under Chapter 4. So much as we have the jurisprudence that guarantees some of these rights that are malleable to digital health, we need to ensure that our policies and laws speak to the people and not just the stakeholders. Include, mention them. Do not exclude, really mention them. Citizenship is not enough. If the policy just says that it applies to all citizens of Uganda, you need to be intentional and clarify on all those aspects, spheres of discrimination that digital health is likely to interface with.
Thank you very much, Maurice, for speaking out on behalf of the several constituencies that you have mentioned. If I can pick one key thing from your discussion is basically all these institutions, the frameworks, the policies that Mercy and Jerome has spoke to, you acknowledge that they are present, but you're saying that they lack the human rights-based approach. So you feel there are issues of privacy, dignity, oppressiveness that are there that you think can be addressed probably during the formation of these laws, specifically to ensure that when we mention citizens, we are actually meaning every person that is a citizen. I hope I got that right. And now I will turn to Mr. Mhumza. Now that you have heard the several issues that have been mentioned, do you think that these current institutions that we have in Uganda that have been mentioned, do you think they are well placed to regulate the health sector? Do you think we have the necessary capacity in terms of human resource, in terms of finances, to be actually able to regulate all these things that we have been talking about? I remember during COVID, we were home and we would see several people's prescriptions on Facebook. You would see people's health status running all over, and then we ask ourselves, is there a regulator who protects this information? And I would like to know whether we really have these institutions being very well placed to do that regulation and ensure that there's data protection and privacy across.
Thank you very much. At the risk of sounding like a broken record, because I might be making reference to some of my earlier submissions. But to go straight to the point, one, I think it's very paramount, and that's what I've been talking about, to have all the stakeholders come and we have conversations. From Maurice's submission, I could tell that we've really not looked into our documents which are governing digital health. If you look at the Health Information and Digital Health Strategic Plan, it talks about equality. And I'd earlier mentioned, these are the principles: equity, centered, client-centered approach. And in that document, we highlight, we mention how we are going to be fair to all parties. And I'm very sure in our health system right now in Uganda, we don't ask questions like sexual orientation, which determines the services that you're getting. At some point, and I know this is a very delicate topic that we are handling, at some point I feel it is hypothetical to some extent that people think they are going to be mostly provision of health services, they are going to be marginalized because they belong to a certain group. we don't even know which group you belong to in the first place. If you go at the health facility level, maybe in the community where these individuals stay, but at least at the health facility level, we don't say, oh, this is, you belong to a certain group, we're not giving you a service. We've been in private clinics here in Kampala. We've been in public hospitals here. I'm not sure I've ever encountered such an experience where someone is turned away for the different sexual orientation or group where they belong. And now these are individual thoughts. They don't represent the government. I felt at some point, when we got a cut in funding, because, this group, first of all, this certain group doesn't live in isolation. Some of them are mothers, some of them are fathers, they have children, they have dependents, they have mothers and, and all those categories who depend on these particular individuals. So, sometimes to come forward and emphasize and keep drumming the importance of a certain group at the detriment of another, other group I see it's completely unfair. As a country, we provide services to many groups of people, for example, HIV medication. It's regardless of your gender or whichever, you'll still access. And if you're going to cut funding for this particular medication, which is very critical, I don't know if you're being fair or inclusive, as we may talk about. There are ways to address some of these issues, but having a group utilize some of the muscle they have, which is the financial muscle, all right, using it to their advantage to have a very unfair play, right, is something which is not very good. I would like to highlight that as a country, the health sector is mostly donor supported. The government, there are little resources, and you asked a question, about finances. I'll be very honest with you that most of our initiatives, even digital health initiatives, are largely partner-driven. And I think now it is more critical than ever that the government of Uganda, us as the government, invest much more in this sector, because that's when we can, determine where the resources go, instead of, being told do X, Y, Z on condition of this. It's completely unfair and not the right thing to do, mostly when we talk about health for all. But moving on, looking at other areas, human resource. We struggle with many things as this country. I will not speak for Ministry of Finance because they do most of the resource allocation. But yes, I think the civil society organization should be advocating to have more resources channeled towards health service provision, because it doesn't affect one person. It affects all of us. In the COVID times, those who think maybe they can fly out for treatment, you saw the situation that we are in. It's a public health issue, in that if you had one person in a village who has Ebola, regardless of your health status, you would still be at risk. So for me, I think if you ask that do we have enough finances in place, the answer is no. We actually have a very big financial gap. Do we have enough resources? You can see that the other day we had failed to deploy interns who are very much needed in these health facilities. The reason was resources. And in the health facilities, the health workers were they are struggling with the amount of work that they have to do. In regulations, mostly concerning digital health, I'd earlier mentioned that ICTs is something new in governments, isn't it? It is something new that we are advancing. And if you had to look at Ministry of Health, for instance, the workforce that is there that is driving the digital health space is very, very small. It is just a division. It's not even a department. It's not even a directorate. So it is just a small division which is headed by an assistant commissioner. And this is supposed to drive, digital health for the entire country. And as a country, we've been restructuring We've had different institutions being put back into their mother institutions. But if you have to look at Kenya, Kenya recently passed what we call a Digital Health Act last month, which is establishing an institution that is focused on digital health because they appreciate the importance. And when we had a meeting with them last month, you know, we were doing much better than Kenya. And we had to ask them, what's the magic? You know, they told us, Solomon, we now have resources. We are able to put up a data center. We're able, in fact, they went and bought devices for their health workers. You can see, there were about 170,000. And the president, Ruto, was on the call with the community health worker. I don't know if you saw that video circulating and was asking this community health worker, how are you? You know, how is your work? How is that moving? But we've seen intentional, but I think most of the, as we talk about digital health, we shouldn't forget health overall, because at the end of the day, that person has to see a health worker. If the health worker is not well facilitated, not well taken care of, it becomes a problem. And for me, that's what I've always talked about. We talk about digital health, but we forget to put the patient at the center of it. It's not about resources. It's not about the technology. We have to put the patient at the center first and then prioritize them. Then that will come with the resources, will come regulations, will come with all these things that we are struggling with. So again, I think as a country, if we try to utilize the resources that we have, the few in a better way, and have our friends in the different categories who need attention, it is okay. Everyone needs attention, but to see it in a broader way, that this health is for all of us. And in public health emergencies, they don't discriminate. COVID did not discriminate, did it? Neither did Ebola, which we had in a recent outbreak. So to look at it in a broader way and address some of these inefficiencies, some of these gaps we have would be a very good thing. Thank you very much.
Thank you very much, Mr. Mhumza, for actually bringing to your statement that you mentioned during your keynote address. You started by telling us that digital health is a right, not a privilege. And the fact that it is a right, that means that everybody is entitled to all these health services. And you have demonstrated to us how some of these structures have equity provisions and their client-centered approach that you mentioned. And you said the services are fairly given to all parties. No one has been denied access to healthcare because of their sexual orientation. So and then when it comes to the financial capacity, yeah, there's a challenge there, which is more like most of the African countries, except that we also have some countries that have very good success stories. We were in Zambia and were very intrigued when the president of Zambia told us that in 2021, their health budget was 7%, and by now, 2023, it is now 12%. Which is still short of the Alma-Ata Declaration recommendations, but at least we see they are closer to 15%, and I think we are still staggering at 7.6.8. We are still there. So I think we also need political will. We can be able to, like how you're mentioning the president of Kenya being the center at everything. And I remember during COVID when the president was at the center of the campaigns of COVID, put on masks and all that, we were on the globe, like everybody was like, you know. So I think even when it comes to digital health, if we can have political heads being at the center of driving digital health inclusion, then we can have very successive stories. So in the interest of time, I'll just have a minute. Not actually, I have a question for Lillian that I wanted, sorry, Lillian, about the role of civil society organization, because we have mentioned several instruments. We've talked about these policies. We've talked about these marginalized populations. And I know the civil society has a key role that they play in ensuring that there is awareness, you know, do people really
instruments that we have been talking about. So
I think from here, much as we've been in this area, we find that there's quite a number of diverse actors, individuals doing same work but different ways, and we never get to have this kind of intimate kind of conversation. So I think that is one role that CSOs can do, and we thank you for taking lead on that. But the other aspect that I need to emphasize, for us to be able to have these kind of engagements, what are doing. That leakage, that does not in most times it does not work in the ideal world. That's what it would be, but most times we find ourselves on different, lines. Civil society is one side, government is the other side, and private sector is somewhere not in the middle, not to the right or left. So I think coming here is what we can do. But before we do that, I think we need to center our work in understanding the actual, problem. And our work at CPESA is centered around that. We take deep dives into, understanding what are the key concerns in this kind of, area. For instance, say, earlier on I mentioned we have a program on data governance, and digital health, governance is one of the key concerns that, we feel needs to be given quite a number of, attention, especially when it comes to, handling sensitive data. We've all heard that, health is one of those kind of, is sensitive. You don't want to, have your data linked anywhere. We saw that during COVID. We saw right now from my neighbor here, the key population, key populations or, minorities, have an issue in terms of, stigmatization. And it is not always right when, a part of you comes out and, you become looked at as that person who has this condition or that person. So we devolve so much into that. And some of the things initially that I had in mind, I think Solomon mentioned them, because we need to look at a bigger, spectrum of issues. We can talk about them, but if they are not anchored in research, if they are not anchored in the needs, of society, then we don't do ourselves justice. So for CSOs, we need to do a lot of research. And on this topic, very recently, just about last week, we released a report on the state of data privacy in telemedicine in Uganda, Kenya, Malawi, and I don't know which other country I need to. And there were quite a number of concerns, some of which we've already talked about. Yeah, it was Ghana, Rwanda, and Uganda. I don't know why I had Malawi. I think someone mentioned Malawi here. Of course, some of the issues were the technological issues that Solomon has rightfully talked about. There were issues of organization capacity, how to handle, the independence of bodies that are doing this work, the interdependency, data moves across borders, the legal and regulatory, anchorings around that. And on this panel, there are quite a number of lawyers. They were talking quite a number of things. Financial, I think that is where government's concern comes in quite a lot. But also this cuts across to, when we look at, say, telemedicine, we have quite a number of, private service, private actors that are vested into this, field of digital health. Cultural issues, I think we had that from Mr. Ibrahim, and these are really the major barriers. But now if you go into dissecting them, then there's an issue. When we are talking today about, say, on this particular moment, we are talking about regulatory frameworks, we are talking about, legislation. Our study found there was quite a number of gaps. In Uganda, we are not just alone, but across, the countries. So it is really a big concern that for us to be able to say that as CSOs, we need to be putting government or, actors, in different, positions to be able to be held accountable on how do they manage, this data. So that is one of the other things. And if you allow me, I'll just need to, away from what government and others are not doing, there's an issue that was quite interesting from this study that I'll take on your role, Madam Moderator, to get it back to the person at NITA, the issue of accountability. I think, yes, it is good to say that we need to hold accountable, and accountability is not just from us, from civil society, but also from individuals, but also from the bodies that are mandated to be able to have this, to take on this role. You mentioned earlier, what NITA is doing, and I think through the Data Protection Office, there is a requirement to have, entities register with the DPO. And in this study, it was quite alarming, and I'm putting it there because we all know about Rocket Health, and it's one of these very, app that came on, and everyone was so excited because it wasn't something we're used to, and during COVID, it came in very handy. But there's quite a concern in terms of how these private entities are handling data, or how they are, being compliant with the data protection, regulations. And one of the things that we found that was, alarming is the compliance reports. Personally, I think I've gone through that. We have quite a number of inconsistencies in terms of, how compliance reports come in. And for Rocket Health in particular, I think they only registered with the Data Protection Office September this year. So you can imagine this is a company that has been having, all this sensitive information and all that. So when it comes to such things, our role for us is to go in, dissect what is on the ground, and be able to bring out these concerns. Without me dwelling so much on this report, I think I can provide you a link after this. Maybe I'll also share it with Halima so that, entities that are here can go in and see what are some of these key issues, especially on legislation and what can be done in terms of, ensuring compliancy, security, privacy, and protection of, of the data that is collected from users.
Thank you very much. I cannot add on to what Lillian has mentioned. So basically with civil society organizations, it's advocacy and research. And that's what we have been doing. So Lenny is going to, we are going to open up the conversation. I am going to request that you remain where you are so that in case there's a question that is targeted to you, you can be able to take it on.
Thank you. So I'll just move the mic really.
Thank you very much. My name is Sarah Kainza. I work with NITA Uganda, and I've been receiving stray bullets right from when the panel took the seats, but my job is to handle regulation and compliance. So I think I'm at the heart of all the complaints that have been raised, but I want to address a number of things, and I'll just address them in twofold, looking at inclusion and regulation. And I'll begin with inclusion. There are many lawyers here, and you'll agree that to mention is to omit. So the approach that government takes in drafting laws is we've moved from mentioning interest groups. There was a time when laws would say, for instance, women can commit adultery, but men cannot. But if you notice now, the law opens it up and says, it can be committed by a human being who is married, who's an adult. So that's the approach that we take, even when we are developing laws in the technology sector. The laws are not just inclusive, like Solomon said, they're actually neutral, technology neutral. The need for laws is driven by the needs of society. The mobile money law that's the National Payment System Act, became very important because they noticed that there are a lot of transactions going on there which could no longer be ignored. So government recognized they should actually invest in that legislative process. You see, drafting laws is not about sitting at your desk and developing a document. A lot of resources go into that. You build capacity for the people who will implement, you invest in people to benchmark. It takes a lot of money, so you don't just draft a law. The same thing with our technology laws. If we talk about e-digital services, health services, the laws that we have in place address that. The same way they will address fintechs, the same way they will address any other form of services that are being provided in the digital space, and I'll tell you how. When you look at the laws, the NITA Act, for instance, it talks about the responsibility of NITA to monitor the utilization of technology in the private and public sector. It talks about our responsibility to ensure standardization in both sectors. So when we are looking at government, we're also looking at the private sector. There is a full regime called the Regulations on Certification of Service Providers. And this looks at people who give you software services and who also sell to you gadgets. We are talking about Rocket Health. Rocket Health has an obligation, just like any other e-service provider, to get a certification from NITA that permits them to provide services. There is a whole team there that looks at the systems of those entities. They look at their quality management systems, their competencies, the people that are handling their services. There are people that review their applications and ensure that before they're allowed to provide services in the digital space, they have actually met certain requirements and standards that permit them to play in a safe, regulated cyberspace. Mention was made about the E-Transactions Act and Electronic Signatures Act, but I want to point out key aspects about those laws. They say the devil is in the detail, and I think it will be an injustice for us to walk away here without talking about how important those laws are to digital health. When we are talking digital health, we are talking about transactions that relate to health services in the digital space. Those transactions are enabled and recognized under that Electronic Transactions Act. That act actually says that it is okay and lawful for you to buy medication online, to interact with a professional health service provider online. And what does it do? It creates rights and obligations for the parties in that transaction. It creates obligations for whoever is giving services to disclose certain information about themselves, so that when they have done something wrong, you know how to find them. The law is not going to recognize the location, say where someone is saying, our officers are found near a big mango tree in some corner that side. No, the law says give us a proper registered address. Tell us what are the rights to reclaim in the event that someone's rights have been breached. there are actually very serious protections in the E-Transactions Act for the consumers. So it is important for us to know that our laws have gone so far in inclusion that they actually protect consumers in the digital space. So people that consume e-digital services, health digital services, are not helpless. They actually have rights. The question is, do you know your rights? And that is why we are here. That is why NITA is here also, because it is our obligation to make sure that people know that they have rights in the space. You can actually claim and enforce your rights because you're entitled to them. There are laws to that effect. Now, I also want to talk about the national backbone infrastructure, and Solomon mentioned this in his keynote. That infrastructure, just like any other form of infrastructure that promotes utilities, is very expensive. And so we have recently obtained a loan from the World Bank. It's actually it's called UDAP, the Uganda Acceleration Project. Now, this project is supposed to help us to expand that infrastructure to ensure that more and more people can access internet, because you know, if you don't have internet, we are not even going to talk about services in the digital space. So that infrastructure brings it closer, the possibility of extending internet, it brings it closer to those communities which we are talking about, where we'll have to put our phones in particular corners to access internet. Government is saying through the national broadband policy, if there is infrastructure in place X, MTN, Airtel, you don't have to construct. Utilize what's there so that my grandmother does not have to incur the cost for your expenditure. We are making use of those partnerships. We are serving the citizens of Uganda, trying to make it easier and accessible through those different collaborations with the public and private sector. So inclusion is not just about interest groups. It's about each and every citizen. We are not going to say, no, now women have suffered, children have suffered. No, it is every person that is in this country. How can we serve them with the few resources that we have? That is the approach towards inclusion. The challenge would be where we are excluding groups of people, which has not begun, which has not happened. And I think that we really need to capitalize on the fact that even the globe is recognizing that Uganda, whereas they have not arrived where we want them to be, they are making progress. And how do we sustain that progress? That is the discussion that we really need to have. Instead of saying, no, you're not doing this, you're not doing that. No, what are we doing now? And how can we extend those frontiers to ensure that we reach all those goals that we want to reach? So I would like to request even every person here, because we all represent different interest groups, the knowledge that we get today, we should be able to share it and recognize that, yes, our country is growing. We want to reach a point where we have laws that are specific to the digital health space. But then what we have now, we are saying, is sufficient to enable, innovate the frontiers to grow further. Thank you very much.
Thank you. I'll have Cynthia, then Onyait.
Okay, first of all, I want to thank everybody that has spoken from all the different angles. So we've been talking about, I heard the 2040 roadmap, I heard there are laws, there are frameworks, whether they are properly defined or they're not properly defined. My question is, with all the health apps that are coming up, with all the effort to push for digital health, you spoke about patients, you spoke about us, the consumers, right? So I want to find out what's the take on informed consent, because you're collecting our data and you're using it when it comes to collection, usage, and dissemination. Because when I saw some work that Ahaki has done, most of the health apps are developed by foreign entities in partnership, definitely with Ugandan health authorities or whatever health system. So what are we doing, or what is the Ugandan whether it's the legal framework or it's the health systems doing it with respect to informed consent. Because when we're talking about health and we're talking about patients, patients have the right to be informed and they have to give you that consent to be able to use their data. So is there, are we respecting consumers' informed consent before we are even rolling out applications, people are using them? Are these consumers aware that they are supposed to give consent for their data to be used? Not that you just wake up one day and you find your information somewhere. Because somebody who is informed can be able to tell you, okay, I don't want to give you permission to collect this information. I don't want my data, I don't want my information to be online. But we are just rolling out the apps, everybody's using them, everybody's having fun. So what are we doing about informed consent of patients with respect to digital technology?
Thank you. I think you'll be on the panel responses after. Okay, we've taken note.
Thank you very much. And I want to thank all the speakers. I have a number of concerns and questions, so I'm going to throw them to the responsible people, and I hope they'll get answered. I want to start with Madam, I forgot the name, from NITA, yeah. Information is quite important. Awareness is a very critical aspect of everything we do. When you lack awareness about something, there are chances that you will not do it right. When addressing us, you talked about so many things. Talked about the clients, for us that we call clients, we, the online health service providers, talked about the clients, talked about, in other words, the consumers. But you did not talk about the aspect of we, the service providers that provide these services. You talked about the processes we have to go through to register and all that. I want you to pay attention to the bureaucracy. I don't want to sound political, but I want to talk about the bureaucracy in our government. You want to get something done, it's going to take you ages in this government. You want to get a license, it's going to take you ages to get that license. You want to get registered something, if you do not have money, you're going to wait for months. You go to this office, they're like, I haven't had lunch. You have to put there some lunch, you have to put breakfast at evening tea. Those are things that are crippling us, the service providers. And another thing is we do not have this information. Online health service providers do not have this information. So what are you doing as NITA to make sure that this information is spread out there, not only to the consumers, but also to the service providers? How many service providers know that you have to go and register with the data controller, you have to do what? How many of them know this? Then how do you expect to enforce something that people are not aware of? I'm done that side. Let me change my guns to this side. I want to start with Solomon. I heard you speaking and I'm like, wow, this is amazing. But I don't know if there are people that do coding here, because if we're talking about digital platforms, we're talking about digital health, then we are looking at engineers, people that code these apps, these platforms. When we are talking about accessibility, affordability, but let me start with accessibility, sorry. You talked about the internet, the fact that there are places that do not have internet and all that. And then you talked about having software that is user-friendly. Most of us here, the language we are using here is English, correct? I've not had anyone use Uganda, I've not had anyone use Ateso or whatever. Now, most of the digital platforms we're using are in English. What if we engaged the stakeholders that do the coding to a point where we have apps that that are in our local languages? For example, click here, Nyigawano. Something like that for someone to know, because if we sit in these rooms with SC, speak the good English, talk about these laws, they're not even in Uganda, they're not in local languages. We are talking about digital platforms that are not in English, and we're leaving out everyone. We're talking about inclusivity. How do we talk about that accessibility, inclusivity, yet things are in English? And then the last point maybe that I'll put across, I don't want to sound political, but this goes to Solomon. We need to get serious, because we need to be honest with each other. If you're going to have honest conversations, then we need to be honest. I heard also my sister Mercy talk about it, the lack of resources. You also talked about the lack of resources. But let's be honest. Is it really lack of resources, or the priorities are different? Let me give an example. If the digital health we are talking about right now and the health sector as a whole had something to do with State House, had something to do with security, would the money be there? It's just a question. So is it really a lack of resources or the priorities are just different? Thank you.
Anyone? You will actually maybe reduce some of your burdens. Yeah, so mine is looking at the fact that so many people have talked about collaboration. Solomon has talked about it. Mercy. First of all, we'd like to commend the government, that is the Ministry of Health, NITA, and the PDPO. They have really tried their best to push this burden, this mandate of theirs of regulating the digital sphere in our country. And then, but the challenge is there's no what we call awareness in the societies between amongst the communities, the digital health app developers, the pharmacies that are offering online deliveries, the drug shops and clinics. So I would suggest that the government, that is the three that are here today, maybe they could enter into what we call a memorandum of understanding with maybe the National Drugs Authority that is in charge of issuing licenses and permits to these pharmacies that we see today. Because I understand that the National Drug Authority law does not envisage a situation where a pharmacy does online, takes online orders for medicines, right? Yes, so I would suggest that maybe they could enter into a collaboration to make sure that each and every person whose license is renewed or given a new license shows proof of registration with the office. Say they make sure they have registered with the office before they get a license, you get. So that could maybe reduce of these regulations and laws that we are talking about today. That is going to be one perfect way to see that that is executed. Yes, so that's my comment.
Thank you very much. First of all, colleagues, thank you for all the feedback, questions, and comments. I was hoping not to say this in this forum because of the can of worms that it will most likely open. But the challenge that we are facing in the digital health space is the challenge of formalism. And I'm saying this in response to the submission or part of the submission that Madam Kainza made. And why do I say formalism? You see, when you're trying to regulate sex, you don't start with the institution of marriage because you expect that sex will be happening there. You start with the illicit avenues in which sex, so you may run to prostitution, you may run to brothels and things like that. Similarly, when you're attempting gun regulation, you don't go to the regular forces, to the police or to the army. You'll want to start with criminal gangs and stuff like that. The point I'm making here is digital health is burdened by formalism. We are trying, or at least assessing ourselves based on digital health in spaces that are easy to regulate. And I think I said this at the previous conference, Solomon, when you see a health worker in Mulago sharing data to another professional in Butabika Hospital, that's easy. That's easy to regulate. It's easy to mitigate risks. It's easy to, when you go to Rocket Health, they're required to register with the Data Protection Office. Easy peasy. But the real challenge for digital health are the unregulated spaces. I mean, you've mentioned NITAU is on top of things. I suggest it's not. And the reason I am saying that is I did say at the previous conference that I have 3 health apps on my phone. I transmit my data on these apps, my BP, my blood sugar levels. Now it gets worse because people take health determining decisions based on what they get here. If my app tells me that I am pre-diabetic I could go to a pharmacy and say, give me glibenclamide. And they'll give it to me. And then I'll swallow it. Who knows, tomorrow I pop dead. Now NITAU is saying we are regulating Rocket Health. Fine. Are you regulating phone applications, which the majority of Ugandans are using to make health determining decisions? Can you tell us, at least in this forum, where my data goes if I input my HIV status in an app, or my BP, or my... Can you tell me where my data goes? Is it in China? Is it in Seychelles? Is it in Cyprus? Is it on a server in Uganda? Now those are the questions that a regulator, in my view, should be concerning themselves with, because that is where the majority of Ugandans are actually making decisions. Maurice mentioned inclusivity, and I'll tell you this, although Solomon is a man of sweet words, but the elephant in the room really is that sexual minorities are not included in our healthcare system. We can bring so many policy documents. We can say no one asks you for your sexual orientation when you visit a health facility. But I'll tell you this as a health worker, not as a lawyer, that there are certain things you can present with in a facility, and I'll know this person is most likely homosexual. You don't have to tell me. Or at least is having MSM. I think that's sex, men having sex with men. There are just certain characteristics that you don't have to show me a document and say this facility does not discriminate. Now, it cannot give confidence to a sexual minority because of a document that Solomon has said exists to go to a health facility in light of the reporting obligations in Section 14 of the Anti-Homosexuality Act, like he mentioned. Because again, the only excluded privilege is a client advocate privilege. The rest, by the way, all professional privilege can be dismissed on account of public health. If you tell me you're HIV positive, for instance, but you also disclose to me that you intend to go and have sex with a certain person, Y, who may be negative, I have an obligation, despite my Hippocratic oath, to disclose what you're about to do. So, it is very clear that there is some legal legroom for a health worker to actually report a person, a sexual minority, to the authorities on account of their health-seeking behavior. Now, why do I bring this up? Because this person then will tend to use phone applications, to use other impersonal mechanisms of enhancing their health. Now, I highly doubt that NITAU is on top of things in the app space. Because the first question you're going to ask, where is the data holder or the data controller to begin with? Are they in Uganda? Are they in China? Are they in Cyprus? Are they in Dubai? Now, the second thing, back to formalism, is a bite of NITAU. It has been disclosed here, and I have no reason not to believe that Rocket Health, for instance, registered in September this year. Now, the DPPA and its entire regime is 2019, with the regulations, I think, coming in 2021. 2020, right? 2021. So that is the regime. I highly doubt that between 2021 and 2023 September, there has been any citation, any sanction to Rocket Health that, by the way, you are operating outside of the confines of the law. It seems more like, the regulated has to agree or to permit NITAU to regulate it. I have not seen any bite, at least for some of the big players. And this, by and large, happens all over the sector. Already, and I think Solomon can confirm this, there have been pilot studies in public health facilities on using digital technologies, various digital technologies. Now, those are already data controllers. Now, has NITAU said, okay, government of Uganda, we know in the health sector, you're operating 258 health center 4s. Of those, 200 are already, collecting patient data, which is defined as personal information under the DPPA regime, which has the highest level of protection. We need you to register with the Data Protection Office. These are things that are already provided for in the law, mechanisms that are already there, but there is also a tendency, or at least some laxity, outside of the resources debate, because I don't think authoring a letter to the Minister of Health and advising them that you operate all these facilities, they are collecting personal information, can you give us, whether you meet the standards in Section 3, the data protection principles, are you satisfying these things? I don't think that that is happening. Lastly, on the point of formalism, even when you share, how much are you sharing? Is it blanket sharing? Like I said, if I attended an HIV facility for HIV services and tomorrow I have a headache and I happen to be seeing a doctor in Kamuli, whereas my HIV treatment is obtained from Mulago, are you going to send my entire medical history? Or are you going to send only that is relevant to my headache? And what role do I have? Of course, the law says I have to give permission, but how practical is it in resource-limited settings? And I said we don't have to discuss these things in the abstract, because the reality is we have a very, very, is it high or low, doctor-patient ratio. And I was saying the idea that I could be before a doctor that has taken me hours to see, and then I tell them, don't share this, share this. Like, there's already gratefulness in just being able to see the doctor. And now they are saying, we are referring you to Butabika, and I'm the patient that says, no, wait, exactly what are you sharing? Does that register in the doctor's room or office? Most likely, I will be just grateful that I have been seen at all. I am aware there is a long line behind me waiting to see the same practitioner. The same practitioner is aware that they don't have time, and they're not even going to entertain that kind of discussion. So Ugandans, we are given healthcare mostly as a privilege. We'll say it's a right, but that's if you've not been to a public health facility and faced the dynamics in those facilities, where a patient is so disempowered that they will take whatever is given. Now, this is the same patient that you're going to say, you know your rights, because Madam Kainza, you said, data, these people, consumers know their rights. There's a lot of consumer protection. No, you said their rights. Their rights prevalent in the regime, right? Data users have rights, the data subjects have rights, but are these rights capable of enforcement, in your view? Can I, as a patient, be in Mulago Hospital, wait from 8 a.m., be seen at midday, and then I begin telling the consultant, you can share this, you can't share this, you can't do this, you can't do this. How possible is that interaction? So I just wanted to ground that conversation in reality. Yes, we have very good laws. He spoke of English, laws that are in English, very marvelous laws. I eat from those laws. But the issue is, how practical are they in the inclusivity discussion to the regular Ugandan?
I think can we give, there was someone from NITA who wanted to make a response, and then, but there's someone from the community perspective that I think we should hear before the NITA person comes in. Caroline is representing the community.
Thank you so much. I'm glad to hold this mic again. Good afternoon, ladies and gentlemen. Did you know that I can send 10 million shillings from here to USA to someone at zero cost right now, and someone receives the money in 1 minute? Did you know that? Does any one of you know that? You're hearing from me? Thank you. So it's in reality, it's already happening. I can do it even right here. I can even practice it right now. But of course, there is no need for that. But at least you are aware now that I can send money from here to wherever I want to send it to, and someone receives the money in 1 minute at zero cost. You are aware now. I've told you that. If you need to know more, you can consult me after here. Now, Now, there is something I'm like trying to share with you people. I'm just a community personnel. I only know, I don't have any qualifications. I don't have any education background. I don't have any AI technology knowledge. I have not learned anything about technology, but I can do what I've told you in just 1 minute. I can teach my child of 8 years to do the same. My mother, who is a P2 graduate back in 90s or 80s or 60s, she can do the same. Now, I'm one of the people who used to ask myself questions that, can I receive money through this? I used to have the Kapesa, the Katoch phone. So I used to ask myself, can I receive money through this phone when they introduced mobile money? We are talking about digital health, but it also touches digital finances or digital currencies. It is the same thing. Everything is graduating from analog to digital. I can sit down and know the type of prescription the doctor is supposed to give me before I visit the health facility. Today, using the health apps from my phone or Googling from Google, I can now talk to my mother every day on Google Meet. When she can see me, I can see her. We laugh, we chat, everything. She can show me where she is, what she's wearing, how she's looking. I have pimples. You see, I need this kind of jelly. When I've not gone to Kanungu, to those hills where I grew up from, where our network used to be your voice to communicate to another person on a different hill. My father used to stand on the hill and then call you when you are down in the valley, and then you'd respond by the voice, and he would also hear you. But today, everything is almost eased, like it is eased. I've not gone to the village, but I can still talk to the people. They don't miss me, I don't miss them, because I can always access to talk to them. Now, me, I'm not seeing a challenge, by the way. You people are talking of challenges, but I'm not seeing a challenge. You people you are seeing challenges, but me, I'm seeing a very high speed at which internet or technology is moving things. I do not know. Is it because I'm too old? Is it because I'm not educated? I don't know. But you people, I'm not seeing a challenge. If my child of top class, just top class, can sit down and ask me some questions which I never asked my mother when I was in secondary school, even at senior 4, even at senior 6. I never used to sit down and reason, ask my mother a certain question, a certain health question. By my top class child asked me a certain question. She is just 6 years old. I looked at myself and I was like, where are we heading? She does not own a phone. She's just there. But she can sit down and watch me using my phone and tell me, now I know the pin of your phone. I can hold your phone and call so and so, whoever she wants to call, as long as she knows the name I've saved. I never used to do that. Even when I had finished senior 6, I could not hold the phone and search for a contact or call somebody. I didn't know how to use it. But today, this generation, you people, there is no challenge. I'm not seeing a challenge. I'm not seeing a challenge because at my age, I'm too old. I'm not educated. I don't have any qualification, but the things I can do on my phone today, even right now where we are sitting, I'm making some money. Digital currencies. Some people are trading Forex. Some people are having Forex bureaus in town. They are having Forex bureaus. Forex bureaus have been in existence. The Forex bureaus are holding paper money. They are exchanging paper money. You have Tanzania shillings, they give you Ugandan currency. You have US dollar, they give you Ugandan currency, or you want dollar. They are handling that. I am handling digital currencies. I can do it here and make good profit. So, to me, the world is moving at a very high speed because of this internet. And very soon, even the villages you call very remote, many of them nowadays, wherever I'm visiting, I can have internet and I can still do whatever I'm doing. Very soon, we are having these new telecommunications, like we have Leica, which is making internet very cheap for everyone, though it's not accessible in some areas, but I know very soon they will also sort that out. Data in the hospitals, someone would write pieces of paper. Okay, let me not talk about the hospitals, let me talk about schools. The school in which I attended my A-level or my O-level, they never had computers. They used just to have their books where they have their roll calls and whatnot. But today, if I completed my senior 6 in 2000, I can go back to that school and they will locate my certificate, or if it is lost, but they still have my data, even when they didn't have internet. What about today when internet is provided? Even the laws which are supposed to be set to govern everything and how it has to be shared. Since we have something like a haki, which is concerned very much and is bringing in all these intelligence to come and have a discussion on what should be done, then everything very soon shall be sorted out. Sincerely speaking, have a blessed day.
Wow. I think she said it all, really. Ahaki is working when she says even the remotest of the remote villages. You know, she can talk to her mother, she can pay fees, she can, get the results of her child. It's because that school has internet. Now, let me take you back a little bit. Mention was made about NITAU, but from what I gather, there is kind of confusion between the mandate and responsibility of NITAU vis-a-vis that of the Personal Data Protection Office. As we speak, these are independent. One is a government semi-autonomous authority, that is the National IT Authority, National Information Technology Authority, that came into existence in 2001, 2011. And then the Personal Data Protection Office came into existence in 2019. It is a department, but NITA supports because it's the IT authority. And from that IT, that's where we build to carry out what we do. Now, the core mandate of the National IT Authority is to support the government, to give each and every, like she said, National Information Technology's core mandate is to give internet services to government departments and ministries such that they can serve you. That is why you can register a resolution online, you can examination results online, you pick your passport the way you do, you don't have to go line up at 4 a.m. to make an application, you pay your taxes. There is so much you can do simply because we are giving government the internet services. And then these services are being decentralized even in the remotest areas. Am I correct? I think that lady is now a living testimony. You see, it is one thing for me to have internet by MTN or Celtel. It is private. But the only one I'm going to be able to communicate with her, she's maybe a nurse in a health center, 4 health center, 3 in a remote village, is because the government, through World Bank projects like RCIP, the Regional Communication Infrastructure Project, the UDAP, World Bank projects such as Uganda Digital Acceleration Project, they fund these projects and we take the national backbone infrastructure as far as Gulu, Arua. We have 6 cities that are right now powered with internet at the districts, at the local councils, at the municipals. the health facilities, the education facilities, all government facilities have the internet. It is because it is one thing for me to have this gadget. It is solely private. The phone I purchased, the internet is by MTN. But then it is useless if I cannot communicate to my mother, who is a nurse, who works in the market. We have powered all those, you know, those local areas like deep down in the market. So when my brother talked about national information technology being government-centered, it is giving government the power to serve you better. Let us, I think, clarify that. And then the Personal Data Protection Office came into existence in 2019. And we all know that the government aims to digitize the economy. And with digitization, there is so much that goes on. A lot of information is being exchanged. So personal data protection comes in to create some kind of perfect competition, some integrity, some sanity. Because we know personal information is part of the data that exchanges hands. All of you have mobile handsets, but the rate at which you get excited by an app and you go to your Play Store, your Apple Store to download this app, do you even take the time to read those small terms and conditions? When you're buying a SIM card, do you know the terms and conditions? Can any one of you just make one statement for me regarding the terms and conditions, regarding those electronic, applications that you use for the services you access? You can order for food, you can order for medicine from Frika Pharmacy. You can do so much. So that is the clear distinction. With the Personal Data Protection Office, it is to ensure that me, Edna, for purposes of the law, I am a data subject. And then Sarah is the government who is going to collect information from me. Then this gentleman is a private entity that is also going to collect information. Maybe he works for an NGO because they need this information, they need this data to write a project, to sell the idea to a certain investor. They need my data. Amongst the volumes of data they need is personal data, but are they using it for lawful purpose? This is how the Personal Data Protection Office comes in to create awareness to me, Edna, the data subject, to enlighten me about my rights. And I believe if I know my rights, automatically the person who comes to collect this information will have obligations to meet when they come to me. It is me. It begins with me, brand Edna. I know this is my right. You have to share this information. This I'm going to give you. And for me to appreciate, I have to be involved. There has to be integrity, transparency, minimality, retention, all those principles. So that's the clear distinction between the parties. Rather, the two, I have said a lot. I wanted to say some more regarding some of the mentions that were made regarding health facilities having internet that is powered by the government. And these are health facilities that we go to. Regarding the private facilities, these ones may have internet by this data, but we have some principles, we have policies in place. I know Rome was not built in one day, and because the Personal Data Protection Office came into existence in 2019, we haven't even gone, should I say, a small fraction of what we're supposed to do. We are trying, we try as much as possible to make noise about my rights as a data subject, your obligations as a data collector, but we are limited by funding. From the little that we have done, well, there are people that have responded, and we have brand ambassadors who are supporting us. We are trying to look for donors to fund initiatives to ensure that personal data protection is, grounded up to the grassroots. That's why somebody talks about you go to hospital, you go to a government facility, and you wait from 8 a.m. and they serve you at 2 p.m. But at that point, you don't even have the capacity maybe to refuse or allow or accept. Some of these things are beyond our pay grade. Like I told my colleague, when we talk about corruption, some of this corruption is perpetrated by us. I come into a line in a bank, and because I feel I have more money, I can pay the police guard to kind of take me behind. What is that? Isn't that where it begins? you're in a lane, we are in traffic jam, and you have your kids behind you, and they see you jumping the queue, you're using the pavement. What are we doing? And then we are blaming corruption on the government. So it begins with you, everything begins with you as an individual. Changes are going to come, but then how do we embrace this change? So for me, the little I can give all of us is, yeah, we know our country, the challenges we are dealing with. But then me as an individual, Brand Edna, what am I doing to kind of help the situation? Instead of putting the blame game, then what can I say? Wanting to be vulnerable in front of everybody. Because I am the data subject, I am the persons with disability, I'm the LGBTI. Let's look at it from the other angle. Let me try to fall in line. But then again, this is our country. There are some things that are beyond my pay grade, just like all of us here. Are we correct? Ne tukoleche tusobola. Thank you very much.
Halima, please guide.
And there's supposed to be another panel here that speaks to those persons. And I see we've taken a lot of time on just this one segment. So I will only allow questions that they were directed to you, and you can use a few minutes to respond, and then we quickly bring in the other members so that we do not only stop at hearing Data Protection Office, NITA, Ministry of Health, because we have persons from academia, we have app developers, we have professional councils, the Pharmaceutical Society of Uganda. So we'd love to also hear from them. So quickly, Solomon, you will, yeah, thank you.
I'll be very brief. I think our colleague asked us about the platforms which are in English, and I'm glad Miro is here today. In Buyikwe, we are piloting our community health information system in Uganda. It has been the first time we're doing it, and that study is going to end 31st of December, and then we shall come up with a report and then justify its translation into other languages. At least we know that most of the community health workers, really their level of education is not that high, and they prefer to use local languages for that, but it is still not scientific. We need information, and that's why we're conducting that research. It has been ongoing for 6 months, but at least as government, we've taken that effort to translate our first health application. That is for the national application, but I know if you go on Play Store, you'll find other applications in other languages, but this is the first time we are doing it, and we are generating evidence to be able to inform how we handle other systems. I hope that is sufficient. You've talked about the issue of resources. I think I'll just leave it at that. I'd mentioned earlier that as Minister of Health, we utilize what we receive. We are not an agency which does resource allocation. So again, I think it's a very good call that you put forward. And I think as CSOs, this is where the advocacy comes in to, you know, to tell the highest of the echelons of government to be able to prioritize some of these areas. So again, the issue of pay grade, that's why as Minister of Health, that's why it would stop. But CSOs, it's your responsibility to advocate for resources to be channeled where they're needed most. Thank you.
Thank you very much. I'm going to request my panelists to take their seats. Thank you so much. Frank, without wasting time, I'm going to invite you to take on the next session. We apologize that the discussions have been so interesting that we could go on and on and on. Dr. Miro, I apologize, and I know that your question will come on because you're still coming in this other session. I wouldn't want our stakeholders that we have invited to go without saying one or two words. So Frank, I hand over to you to take our session.
All right. Thank you, Halima. First of all, I didn't introduce myself in the beginning. My name is Sekamo Frank. I am a research associate here at Afya na Haki. I am a lawyer by profession, but I'm also a human rights activist. I am a Master of Laws candidate focusing on digital health in Africa. So this conversation right here today is right at the center of the things that I want to do. Without digressing, I would like to invite the following people to come for a panel discussion. Dr. Milo, please come and take the stage. Mr. Patrick Onyaiti, please also come. I want to emphasize that we don't have a lot of time on our side, so we'll make it this quick. So, Mr. Selias, please also come. Madam Nakandi, you're welcome. And Madam Patience, please also come. And this is a continuation of the conversations we've had in the previous discussions. And the panel, and also we've had think tanks here and other stakeholder meetings, so this is a continuation. If you have said something, if you have heard something, there is no need to regurgitate, we just move. I would first of all give you 30 minutes to introduce yourselves, each one of you. Thank you.
I'll take one of those 30 to introduce myself. I am Miro Krish. I'm a pharmacist by training, practicing researcher, and I currently head the research department at Mobi Clinic, one of the developers and implementers of digital health solutions to the last mile areas. Thank you.
Good afternoon once again. My name is Onyait Patrick. I am a lawyer, I am a counselor, and I am the founder and CEO of MindWatch Foundation. What does MindWatch Foundation do? This is a non-profit organization dealing mainly in mental health. We provide digital mental health awareness, and we provide online-based services. It comes something like therapy, for example, online therapy. Thank you.
Good afternoon. My name is Sirias Andrew. I'm representing the councils, regulatory bodies. I'm a systems administrator, Allied Professionals Council.
Good afternoon once again. I'm by names of Nakandi Maimuna, working as a community manager with Baobab Circle Uganda. We are a health tech company, and what we focus on is providing a solution that is a peer PAP to enable people easily access doctors telemedically.
And my name is Patience Atkunda Jafu. I work with Accure. Accure is Ernest Cook Ultrasound Research and Education Institute. It's an other degree awarding institution transiting to Ernest Cook University. We've been in the other degree awarding institution status for the last 22 years. So we're just transiting to Ernest Cook University, and our focus has been mainly on medical imaging, but we are scaling up to the other programs because of the university name as a requirement to do that. Accure also is a health care provider, mainly for medical imaging services. And so we run a number of medical imaging centers. And we also do a lot of research in health and mainly in artificial intelligence and machine learning. Thank you.
All right, I want to start with Mr. Selias. Your colleagues have been facing the shots, and you've been seated comfortably. Now I want to turn the guns to you now. I know you're coming from Allied Professionals Council, and your work is to regulate these professionals that also provide health services to the community. So it is not only the role of NITA-EU, Personal Data Protection Office, and Ministry of Health. I know you have some powers to also do some regulation somewhere. So I want to ask a question. Do you think the regulatory framework you're working within is sufficient enough for you to regulate and to ensure inclusive digital health in Uganda? Or if it's not, what do we need to do? Please make it quick. I'm sorry for putting you on.
I understand time is not on our side, so we'll try to be precise like you have suggested. One of the key components in the digital health is the health workforce, and these are the practitioners. So it is a key component which we cannot do away with. And as Allied Health, we have 4 councils in the country. That is Allied Health, Nurses Council, Medical, and also Pharmacy. So what I say cuts across, much as some of them are not here. And in our mandate, we are supposed to register these practitioners. We're also supposed to license them to practice. We regulate their training and also their practice. So it starts from the training institutions, we register them, then we also regulate their practice. Why am I saying that? For digital health to be effective, first of all, we have to identify who is a genuine practitioner and who is a quack. Previously, we have been having issues of masqueraders in the health sector. I think you're all aware. Last month, we just arrested one of a person claiming to be a dental technologist. The person was from Kenya, came to Uganda, started practicing. And we got a tip from one of the community people that this person is lacking, and actually we went down and assessed. The person has never stepped in school. So even in the digital health sector, much as some services are online, but you need to understand, is this person offering the service registered? Is the person licensed? Okay, because someone can prescribe for you medicine and yet the person is not qualified and you get side effects, as you always hear people complaining. So that is our role, and we have done so through registration of these people. And also, after registration, we have to ensure that every year they keep on renewing and also getting continued professional development, what we call CPD. So for inclusion purposes, for our practitioners, what we have done, we have developed an online system. It is called the eHealth licensing portal. And what this does is that it helps these practitioners who are going to offer you services to get their licenses in an efficient and modern way. Previously, those people used to move from across the country. Someone comes from Karamoja, has to come to Kampala to get a license. But right now, we have digitized everything that within 5 minutes, someone using their phone, they can be able to apply for a license and they get it instantly. So we have made it very easy for them so that when they are giving you services, you're working with people who are licensed to do what they're supposed to do. So, and again, on the other hand, as a regulatory body, people, my sister from NITA was struggling to convince you, but as a regulator, we also have a role to play. They may not play all the roles. So on our side, in case you get a service from a practitioner, and even if they're registered or licensed, but they don't meet your expectations, you are free as a client. It's good that we have a person from the community. You are free as a client to report this practitioner to the regulatory body, and we have disciplined so many of them. We have had rape cases, for example, most especially for radiographers. Client comes, they are assessed, and during that process, the practitioner gets sentenced, and sometimes they rape these clients, and we have handled those cases. Then we have had cases of misconduct, for example, disclosing information about the patient, which is not legal, okay? So because you are supposed to protect this person's data. So in case you disclose, which is not allowed, the regulatory body can take you on as a practitioner. So we do the whipping on the other hand, and also as DITAU also does the other part. So like you have seen, we are coming from different sectors and each person has a role to play. So in a nutshell, that's what we do in seeing that we have an efficient digital health.
Thank you so much. I think that is well summarized. I take the note that we have around 4 professional councils in the country, and you're responsible for regulating the professionals, also enforcing disciplinary measures against them. So I would like now to go to who now do I go to? I have not arranged my questions, and I feel like it's a lot of things that have been talked about, so I cannot flow very well. But for now, let me go to the community person. I know you're a community manager somewhere, and I like your app. I've seen your app, but now I want you to speak from a community perspective. Madame Carol has intimated to us that there is no problem. Now, you as a community manager, where you're working from, I know you've engaged with so many people, so many diversities from around the country. So I want to know, do you think there is a gap in the digital health landscape in Uganda in as far as the community is concerned? And if so, what should be done? Thank you so much.
Thank you so much. Actually, yes, I think there is a gap. And I think I will differ from her. It's quite evident. I will take a case scenario. I work with AfyaPap, Baobab Sacco Uganda. And like he said, we are currently implementing a solution, which is AfyaPap. And what does this do? It helps someone with being able to continuously monitor their health vitals, that is for blood pressure and then blood sugar. So in reference to that, one of the things we have continuously noted is that not everyone can speak the English. Not everyone can actually interpret these numbers. And of course, these numbers are usually in English. So I talk about the gap in that case scenario. One of the things that has continuously been noted is accessibility as well. I can confirm that most of the applications that are developed by the app developers, I can usually be accessed on the smartphones. So what then happens to that old lady in the village, that old man in the village that has no smartphone? And when you talk about the smartphone, you would need an internet connection. Do we have internet everywhere? Do we? No, we don't. So we really have that gap when it comes to that. And still in reference to the aspects within the community, we note that when you are to deeply penetrate into the community, you would need the support of community health workers. You cannot talk about the community without the community health workers. When you look at the current community health workers that we have, these are old people. Not all of them can speak the English. And then in addition to that, we have over, I was looking at the statistics, and are they over 180,000? These are old men and women that can as well not speak English. So when you look at their literacy levels, the levels are so low. These people are empowered to go and preach the same gospel about maybe a particular service within the community. But then what then happens if these people are not well facilitated? We are all aware that apparently what our community health educators or workers receive in Uganda is basically an incentive, which is most of the times tagged to the number of people that they attend to. So if such people are not well facilitated, then it means they won't be able to provide that health care digitally to the people within the community. So I think, yes, there is that gap. And one of the things I think we should do is to really ensure that these people are well motivated, because you cannot penetrate the community without the support of the community health workers. Then when we talk about the accessibility, I think it's really important that as the app developers come up with all those solutions to better improve healthcare, can we have both USSD and then the users that use the smartphones? Then I believe in that way, that will really be inclusive. Yeah, thank you. I think that's it.
Thank you, Madam Nakandi. And that's well said and really well summarized indeed. I take note of the points on language equity. I personally attended the National Digital Health Conference that was organized by Mr. Muhumuza and the team, the Ministry of Health. And I found only one app that has this ingredient. It is made by the World Vision. So it has even the visuals. If it's your name, it will give you a visual of a name, and then it will give you the sound, okay, in a language that you understand. So these are some of the apps that we need. But I want to emphasize that this conversation on digital health does not concern only apps. Okay, I saw IDI, what is it called? Infectious Disease Institute. It is using drones, AI-powered drones, to deliver health services in the country. She has talked about AI. So we have these things here. We have machine learning. We have apps. So it's a lot of things. The other thing is that you say that omuntu wa wansi, the grassroots person, has to be integrated in the system when we are from the designing stage, okay? Even including the VHTs and the community health workers. That's very well taken note of. Thank you so much. Then I want to proceed and go to Madam Patience. You've had apps coming in the conversation we are having. We have AI. So as a person coming from an academic perspective, what do you think we can do better to improve digital health literacy to ensure inclusivity in the country? Thank you.
Thank you. To start with, of course, from us in the academia that do the training of the healthcare workers, and also we do the training of the innovators of these digital health tools. And of course, also looking at now, a few months ago, no, this was actually in January this year, there was an MOU that was signed between the Ministry of ICT and ICDL Africa. ICDL is international. It was previously International Computer Driving License, but it rebranded to International Computer Digital Literacy. And the minister emphasized that currently in Uganda we are below 50% in regarding digital skills. And now, if we are below 50%, and yet we are seeing these several several people in Uganda using mobile phones, several people are coming up with these innovations, and then also not forgetting the fact that we also have so many languages in Uganda, and of course this has been said, but then we need to see how we can utilize these several opportunities that are there. Now, in the academia, of course, as we train these healthcare workers, and we also train the people to also always emphasize, of course, some of these things we've been talking about, data governance principles, and of course, for us at Accurate, we've been very intentional in teaching our students regarding that. And because, you see, these people get to the healthcare facilities, and then these also come with the digital tools. But then if they do not understand these principles, then that is where we get to lose it. They develop these tools, they are lacking some of these key concepts that we've been talking about, and then that's where you get to find patients' data being taken by people that are not authorized to actually have access to it, and several issues around there. So, there's need to ensure that, and I'm glad someone from Allied Health is also here. We know that most of these healthcare training programs, their curricula is centralized. And so we also note that in many of these curricula, there's most of them are lacking the digital skills components, and of course they are training, people are being trained and getting the other skills that need them to serve the people in the communities and in the healthcare facilities, but they are lacking these skills to operate the digital skills. And of course, where we are going with these technology improvements that are coming in, these are the same people that are meant to use these very tools. So if they're lacking the skills, how are they going to use these tools? So we need, and know that they need to incorporate this kind of training in their curricula and be able to train people who are to ensure that there's holistic training. They're not only keeping this alone, looking at where the world is going, they need to be equipped with these digital skills to ensure that even when these tools, digital tools are being implemented in the health facilities, they're actually able to use them. And of course, regarding the languages, we know there's a company called Sunbird AI, and they've come up with a system that a translation system. It uses natural language processing, and you can, of course, as we come up with these tools, we need to be able to ensure the inclusivity that we are talking about, because if you sit down in Kampala and develop this application, and then you need to implement it in the community and find that they do not understand English, then there's going to be a challenge. So with these other companies coming up with these natural language processing systems, we need to see how we can collaborate with them, and I'm glad someone talked about collaboration to ensure that we are not starting from zero. We can actually build up from where they are and be able to, from what they have, and be able to improve what we are doing. The challenge we usually have in Uganda is that we all have to want to build up on what is already existing. We also talked about the Data Protection and Privacy Act earlier when he was giving his keynote address. And of course, we keep mentioning government, and of course, like someone said, we are government. If I can do what is within my means to do to ensure that something that government is not doing, I also do something in relation to that to help them, then this is going to not only help me, but to also help the people around me. So as academic institutions, we need to see how we can help to help government or to work with government to ensure that some of these acts and the policies are disseminated to even the people that we're actually training, because some of these training programs in their curricula, those that have those particular components, especially in the ethics, we need to ensure that we include these and be able to disseminate, especially when we are talking about data governance principles, and be able to disseminate such policies so that people actually know. We may not reach everyone, especially in the community, but if we can start from the people that we are able to get to disseminate to, then we'll be doing something around there. And of course, again, we in the academic institutions, of course, we've heard of so many digital health tools developed from these academic institutions, but you are also aware that there are many of these digital health tools that do not end up in the health workflow. So some of these in the academia start as grant projects. You've applied for a grant, you've won the grant, you've begun to do what you